While you all are getting settled, Maureen, how are you? We apologize for already being a little off schedule, but you find when you work for the state for a long time, there's such a thing as governor time. And by definition, the governor is always on time. The rest of you are just early. But the truth is, he was here on time. We've been giving people a little chance to get through the accident on 66 to get here this morning. It's been a bit of an issue. So because we are a little behind, we're going to change up the agenda slightly. And I'm just going to be very brief, which is to your benefit. But I think we all are here to talk about how we eradicate this opioid epidemic. And today we're not here to celebrate the problem. Most of us kind of know what it is. We have different viewpoints about it that we can share and discuss. But really we're here to think about how we can be more effective in addressing it and the underlying issues related to addiction and mental health and the things that drive those types of problems socially. Mason is making a commitment to work together with the region. We appreciate so many of you being out here for this. I would like to sort of short circuit all the introductions so that we can get the governor back on the road here, if I may. And with that, I'd like to introduce Dr. David Wu. Dr. Wu is our provost, which means he's our chief administrative officer and our leader in this endeavor. And he is an engineer by training. He has this little habit of liking method in science and practice. And he also believes in transdisciplinary work. He realizes that we don't solve things in the silos that we use to create the problems. There's some Einstein quote about that, but we need to think differently, and he's really encouraging us to reach across domains here at Mason to figure out how we can best help the region and help the nation. So Dr. Wu, come up and speak to us and introduce the governor.
Thank you, and good morning. Well, it's a great pleasure and honor for me to be here and welcoming such a distinguished group of partners that I think that by the end of the day, you'll become our partners if not already. I'll be brief. I have three main takeaways for everyone here. And one is, of course, I'm representing George Mason University here as the chief academic officer. And the Mason has always been created with the idea that this university is here to serve the public and to serve our community. And one way we do this, as Bill said, is by pursuing these transdisciplinary research that could really help to derive solutions that make a really socially relevant impact. And that's really part of the point that we are gathering here today. And of course, Mason is an educational institution, and we offer some of the most important programs in terms of producing the kind of workforce our area needs. And for those of you who don't know yet, we are going to have the first School of Public Health in the Commonwealth of Virginia, and we're in the process of making that happen. And of course, another role of the university is to convene events like this. And the idea of today is to bring people together and to pool our resources and to put our different perspectives and to get our community leaders together and try to come up with solutions to address this really tough issue of the opioid epidemic. Now, as a Tier 1 research university, which Mason is now joining the rank of about a little over 100 Tier 1 research university by Carnegie Foundation, And we are also the largest public research university here in Virginia. And so we are positioned to make that impossible possible. And that's why we are chosen to take on this particular issue of eradicating the opioid crisis. So the second takeaway is, in order to do this, we really need to take a transdisciplinary or multidisciplinary approach. And most of you are in the field and understand that this is not the issue just about the opioid or public health, for that matter. It's also about substance abuse, addiction, mental health, and also involve issues like trafficking, distribution, and overprescription, and that involve criminal justice systems and involve public policy. And also there are many of the underlying social factors that really is the root cause of it. And so the approach to address these issues really requires our really exceptional level of collaboration and coordination, right, between the levels of government, community organizations, and field of interest, and of course academic expertise, and expertise anywhere from the basic brain science, criminal justice, to healthcare, to public health. And all of these happen to be areas that Mason has world-class academic expertise. So that's why we're here, and we want to bring our academic expertise to bear to make a contribution. And, but our success will require not only evidence-based best practices that's known, but also new knowledge that's going to be created through research and scholarship. And once we do the research and in partnership with all of you, we want to disseminate that knowledge and have that research to have very direct impact to solving the problem. So the third takeaway is really the point about today. Together, we have the opportunity to have the expertise and the desire to help to eradicate this crisis. So this morning we'll bring the leaders in the field to help us to have a deeper understanding of the epidemic, both nationally and regionally, and help us to understand how this epidemic is being addressed. I know a lot of work has been done, and there are community organizations that pop up every month. And we want to know, what is working, and what has been funded, and what needs to be done. And we will share with you some of Mason's assets. And this afternoon, many of you will have been asked to help us to develop recommendations on what can be done better. And we have these faculty workshops. The faculty researchers from across the campus are going to come together to address some of these very issues. And we look forward to share our findings in the write-ups and to disseminate that outcome to all of you. And so this is by no means the end. This is the beginning of the process for George Mason to take on this initiative and to convene the community to help us to do that. Now it's my great pleasure to introduce our first keynote, and who is the governor of Virginia, Ralph Northam. And let me introduce Governor briefly. And before his inauguration as the 73rd governor of the Commonwealth of Virginia, Governor Northam served as an Army doctor, pediatric neurologist, a business owner, state senator, and lieutenant governor. And Governor Northam is a native of Virginia's Eastern Shore, and he was educated at VMI, and he attended Eastern Virginia Medical School, EVMS, and did his residency at Walter Reed Army Medical Center and Johns Hopkins Hospital, where he was a chief neurological resident. He served 8 years of active duty in the United States Army, rising to the rank of major. As an Army doctor, he served in Germany, treating soldiers wounded in Operation Desert Storm. Governor Northam practiced pediatric neurology at the Children's Hospital of the King's Daughters in Norfolk, and established his medical practice, children's specialty group. He also taught medicine and ethics as an assistant professor of neurology at the EVMS. I think that's the most important part of his credential as an academic. Now, as governor, Governor Northam will work toward ensuring that every Virginian has the opportunity for good health, a good education, and a good job. Governor Northam and the First Lady Pamela Northam have 2 grown children, and one of them is a neurological resident in Chapel Hill, and another is a web developer in Richmond. So let's now give Governor Northam a warm welcome.
Good morning. Great to see everybody. Sheriff Kincaid, Chairwoman Bulova, I think I saw Chairman Randall. Great to see you. It is good to be back in Northern Virginia, and good to be at George Mason University. And Provost Wu, thank you so much. Where Provost Wu? There you are. You snuck away from me. Thank you so much for the kind introduction and just all of the great things that you all are doing here at George Mason University. We're very proud of what you do. And I wanted to be with you this morning to, first of all, thank you for all that you're doing, and also to say that I look forward to working with you in the next 4 years. And folks often ask me what we see as our largest challenge in the Commonwealth right now, and I would have to say it is the opioid crisis, without a doubt. And I know that you all probably know the numbers, but we just reviewed those. We lost 1,227 Virginians to opioid overdose in 2017. And I would like to tell you that the numbers are going down, but they're not. And so we have a lot of work to do. It was really good as I walked in this morning to see, I won't call him an old friend, that's probably not very good to say, but our former Secretary of Health and Human Resources, Bill Hazel, and what a tremendous asset he will be to George Mason as we move forward with this project. So Bill, it's always good to see you. Thank you for your leadership, and we miss you in Richmond, so come back and visit us. Let me give you the scenario as I see it. I know you realize that I wear a hat as the governor, but I also wear a hat as a physician. And I want to give you a little bit of my perspective this morning, as I have practiced pediatric neurology now for about 30 years. And as I tell folks, there's a fine line between neurology and psychiatry. And what often happens, and I've heard this story so many times, is that an individual will go into a provider, such as myself, with an acute type of pain, and they will walk out with a prescription for a narcotic. And if that individual is genetically predisposed and they have access to that medication for more than 5 or 6 days, then they're addicted. And they may come back to me and say, Dr. Northam, I'm still having some discomfort after a week or two, and I need another prescription. And I said, well, that's not a good idea, because we don't want you addicted to narcotics. So then they have no other choice but to turn to the street. And access to heroin is not difficult in this day and age. And as you know, the heroin is now often laced with either fentanyl or carfentanil, which is about 100 times as potent as fentanyl. And so the point being that if that individual is using heroin, and if it has fentanyl or carfentanil, if they don't have something to reverse the deadly side effects, they're going to be a statistic. And that's what happens. And so I see this as 3 challenges, or 3 areas to our challenge. The first is prevention. And I've always said as a a physician, an ounce of prevention is worth a pound of cure. And I'm going to come back and talk about that in just a second. The second is, how do we treat the acute problem? Individuals are often ending up either in an emergency room or in a jail. A lot of them have had a dose of Narcan, and then they're just released and sent right back onto the street. And that's an area that we really need to work on. So the acute management and needing to get these individuals into treatment, such as a community service board, same day. We can't say, well, we're going to give you an appointment for a week from now, because that won't work. And then finally, the ongoing management of addiction. That's something. So I see it kind of as a three-pronged area. But I got to give you an experience that I had that was just really opened my eyes last week. I visited Sheriff Kincaid. I visited a jail in Chesterfield County. And they have a program which I really believe is innovative. It's called the HARP program, Heroin Addiction Recovery Program. I suspect that's what it stands for. I might have last two, don't hold me on that. But I know it's a program for heroin addicts. And I met with about 50 inmates in one room who are male. And then I went over down the hall and I met with about 40 women. And all of these individuals were heroin addicts. And so I just, without even knowing the answer to the question that I posed, I said, how many in here, this was to the males, how many of you started this journey with a prescription to narcotics from a provider like myself? And about 95% of them raised their hands. And I will never forget that. And there was one individual who was probably about 30 years old, a young man who was just as articulate, hopefully, as you and me. I said, tell me your story. And he said that when he was 15 years old, he was a football player, a good football player in high school, and he broke his arm. He had a compound fracture of his arm, and obviously he was in a lot of discomfort, and he was given a prescription for a narcotic. His wound became infected, and for a few weeks they continued to treat his pain with narcotics. And when he finished that acute process, he was addicted. And just his life has been of trying to get one dose of either a narcotic or heroin after another. And what this has led to, this was and is, I believe, a good person who ended up on that path and had really no choice once he was addicted to do what he needed to do to feed his addiction, and that was to get more doses of heroin, and that was then to be able to pay for the heroin, which then got him into the troubles with the law. But here was a man who started out at age 15 who now has 51 years ahead of him in our penitentiary. And he's not the only one. And I said, tell me what it's like when you're addicted. And there are a bunch of them that spoke up and said that it is like the worst case of flu that I could ever describe. It's just, I will do anything to get that next dose. And so I will do everything that I can as a physician and as a governor. And one of the things I want to do is go into our medical schools and teach our students and residents and let them know what happens when they write that first prescription for a narcotic, and start looking at other ways, more innovative ways of dealing with both acute and chronic pain. And that's where universities like George Mason can come in with research and development and looking at new types of medications that are not as addictive as what we're using right now. So I just wanted to share that story with you because it was an experience that, and Stacy, I'm sure you have talked to these folks as well, but I will never forget that. So let's put a lot of our emphasis on prevention, because once someone is addicted, the odds are against them once that happens. And then, as I said, acute management, and I could talk for a while, but you know, one of the things that Secretary Hazel worked so hard on was the access to Narcan. And as you know, if these individuals don't have Narcan, if first responders don't have Narcan, then they're going to become a statistic. And so we want to make sure that's available. And so we, as you know, wrote a blanket prescription last year to make sure that any individual could go into a pharmacy and request that with no questions being asked. So I think that's a step in the right direction. But a lot of these individuals, and going back to my story in the jail, told me the story that they'd been treated with Narcan. They had been in the emergency room, and then they just were released. And we've got to get, once they have that treatment, once they get into our emergency room or our jails, we really need to get them into therapy. And as you know, last year, we put about $30 million into mental health. A lot of that is being used for the opioid crisis. But I want to make my political plug. I'm going to take my doctor's hat off here and put my governor's hat back on. But, you know, there are consequences to limited resources. And we're going to have to tackle this opioid crisis from a lot of different angles. But we can't be leaving money on the table. We can't be sending money to other states who we compete with. So, as you know, we are still working on our budget in Richmond. And there's a stark difference, contrast between the House budget and the Senate budget. The House budget includes expansion of health care, expansion of Medicaid. The Senate does not. And the difference is $400 million, plain and simple. So I asked the question, are we to be in a position where we send $400 million to other states, where we have 400,000 working Virginians who don't have access to health care? A lot of them are our veterans. A lot of them are ending up either in the emergency room or the jails, and so we can do better. So I tell people, whether you agree with the Affordable Care Act or not, it is the law of the land, and let's put the excuses aside and do what's in the best interest of the Commonwealth of Virginia and expand health care so that we can bring those resources to Virginia so we can use them for things like the opioid crisis, things like higher education, things like K through 12, things like raises for our law enforcement and our teachers. So let's do the right thing. And I just, again, I want to finish by saying thank you for being here this morning. Thank you for caring. This is a crisis, but if we all put our minds together and our efforts together, we can overcome it. We've done a lot of things in history, and this is certainly something, if we work together, we can get that done. So thank you. I hope you all have a great symposium today, and look forward to working with you all in the upcoming years. Thank you all so much.
Wow, what a speech to start a day, huh? Well, we're ready to get to work and really bring the best that we have in the room here and also in the community to eradicate this crisis. Now it's my pleasure to welcome our second speaker, Maria Harris Tilden. And she is the Senior VP of the Public Policy and Community Affairs for CareFirst. First of all, I want to also thank CareFirst for their sponsorship in providing the food and refreshment for today's convening. And is Maria here? Yes, okay, Maria.
Good morning, and thank you so much, Provost Wu. I really appreciate the opportunity to be here to greet you today on behalf of CareFirst. The notion that that you are all in the room and focused for the day on what is, can only be called a crisis in our region and our country is really important. I have to also acknowledge the incredible leadership. I think he's been here less than a month. But Secretary Hazel has been a gem for the state of Virginia, and has done important work to ensure access to health care and improve quality in health care. And so it was no surprise to us that among the first things that he did when he got to George Mason is focus on this really important issue, and I commend him for that. We are here today to express and ensure that our support and to acknowledge the work that you all do, but to also underscore the opportunity that we would like to put out to the community. Very few people appreciate that CareFirst is a not-for-profit organization. We serve 3.2 million members across the region, and our goal is to provide quality, affordable health insurance benefits. But in addition to that, because of our not-for-profit mission, we work hard every day to identify ways that we can ensure that folks that do not have access to insurance, who are underinsured, have the same access to the same kinds of benefits that our members do. And as a consequence of that, we've worked over the course of the past 6 months to a year to figure out how we can support the work that people in this room are doing. So hopefully, sometime last week, it caught your eye that we put out a notice for a request for proposals. We are investing $1.5 million for grants in the not-for-profit community for organizations to expand and improve access to substance use disorder programs in the community. Julie Wagner, who is here in the front, is in charge of our community giving initiative, and if you have questions, she's the person that you should tag today. But we want to and know that it is our responsibility to be a part of the solution, and very much look forward to working with everyone in this room today as you move forward to identify ways that you can work more collaboratively together, but also ways that you can identify additional resources to address the issue. So I commend each and every one of you today. I understand that Secretary Hazel was overwhelmed with the level of demand and interest expressed by the community in this symposium today, which is really heartening because the more people that are at the table and recognize the crisis that we are in, the more hope that I have that those 1,200 Virginians that Governor Northam spoke of, we won't be looking at those numbers in the years to come. So, so again, thank you for your work. Thank you for your dedication. And we look forward to being good, strong partners with you as you travel this road. Thank you.
Okay, now, not back to regular order yet, but we're getting there. First of all, thank you, and thanks to CareFirst for the food. Just so you'll know that they're a very, very nice contribution for your food and, well, water today, so that's really important. And I think it's especially important, that $1.5 million commitment to invest in the region. Everybody listening? There are opportunities. We have grant writers. We're eager to help at Mason, so just be aware of that. That's what we wanted you to hear. A couple of acknowledgments. Governor did a little bit of this. Chairwoman Bulova is here with us today from the Fairfax County Board of Supervisors. Chairwoman Randall from the Loudoun County Board of Supervisors. You'll see her on a panel later. Sheriff Kincaid from Fairfax, I see. Barbara Allison Bryant is our deputy at the Department of Health Professions in Virginia. You need to know her. Secretary Brian Moran, you'll meet later, is in the back of the room here. And just for the record, the way it has always worked is that I say something and then Secretary Moran will tell you what I meant to say when he gets up. Okay, so we'll do that. I need to introduce Jody Mans. Jody worked with me for the last 4 years in my office as secretary and is the queen of all things opioid related. So you get to know Jody. Jay Lee is back there. I'm going to miss people, but I did want to point out a few folks that you might not get to meet on the panels. The rest you will. We are obviously about 10 minutes behind, so as you're planning your biology breaks and so forth, the restrooms are out that door across the hall, but we will be running probably about 10 minutes late, and we'll give the first panel a little extra time, and we'll just move everything down and try to catch up as we go during the course of today. So what we're trying to do today is a couple of things, first of all. One is we want people to meet each other. We want the Mason community to understand what the community's doing and the community to understand what Mason's doing. As we've put this thing together and we've looked around the region, there's a lot of energy going into fighting this epidemic, but I've heard there's meeting fatigue. Anybody been to a lot of meetings? Can we help with that by being a little better organized? Are you all familiar with the term collective impact? I believe it's copyrighted now by Stanford, so I can't say that anymore. But collective impact means setting goals and figuring out how you measure them and choosing activities that reinforce each other, communicating regularly, and it requires a backbone organization. As we go through today, can Mason help with that and help ease your load and make us more effective? I don't know if Elijah Johnson from Prince William is here yet or not. Elijah, he's in the back. We were at a meeting the other day, and Elijah says, you know, one of our problems, I got $66,000 for prevention. What can I do with that? But if we add up all of our prevention money and message the same way or similarly in an aligned fashion, would we be more effective? Let's think about how we do that as we go through the day. Now, we have the morning will be panels, some level setting. We're trying to get to the priorities. You'll hear people from different agencies, different domains, different jurisdictions, and learn what the priorities are because that may indicate where the public policy goes and where the money flows. The things that we can take advantage of as we fight this together. We're going to come back after 11 and talk a little bit about Mason's assets. There is going to be about a 30-minute period for you to tell us what's on your mind. We'll have some microphones, and you can speak, and we'd like you to limit your comments to about a minute because there may be a lot of people we expect that want to say something. I will also tell you each of the panels will be short, 5 to 7 minute presentations, and then there's some Q&A because we want dialogue to go. Now, our logistics were such that we couldn't have everybody, but this afternoon we've got 5 work groups around the general topics of harm reduction. Harm reduction is a funny word, but think about it in terms of how do we mitigate the damage that people who are in addiction cause to the folks around them? The crime, the family disruption, and so on and so on. Think about how we communicate and use our systems to help support the people around them. Think about prevention, how we keep people from becoming addicted in the first place. Think about recovery, how we initiate and maintain recovery. And where there's demand, there are always bad guys willing to fill it. So think about how we counter the networks that supply the counterfeit drugs and the illegal drugs. And then finally, think about the culture change it requires to bring people back in to have housing and employment and hope so that they will stay in recovery. And those will be the topics of our 5 work groups this afternoon, so just to know where we're going. So we thank you for being here. And with this, Mark, I've now got you officially 15 minutes behind, but I'd like to introduce Mark Ginsberg. Mark's the Dean of our School of Education and Human Development, and he'll introduce his panel. Thank you.
Well, welcome everybody. Welcome to George Mason. It's great to have so many people here with us on campus today. This really is an important day, and a day that I hope and I know will make a difference in the short term, but hopefully also in the long term, both in the Commonwealth and throughout the nation. Certainly, it's great to have Governor Northam with us and so many other leaders who are making a difference every day in our community and every day across our nation. Quick thanks to our provost and my friend David Wu for his support of this, to Secretary Hazel, one of my newest Mason colleagues, to Jermaine Buck-Lewis, our Dean of our College of Health and Human Services, and many others. Today is a day when our university community, our faculty, as Bill said, across a wide range of disciplines, together with leaders in our state and also at the national level, will discuss and formulate a plan, as Bill so wisely talked to us about this morning, to address one of our most pressing and one of our most devastating problems. As the governor said, last year in Virginia, more than 1,200 people died as a result of opioid overdose. Thousands more died in the Middle Atlantic region and tens of thousands more across the nation. Since 2010, heroin overdose deaths have risen in Virginia more than tenfold, and opioid deaths from synthetic opioids, including fentanyl, have risen even more dramatically. Personal tragedies are immense. Tragedies for our communities are incredible, and the human terms, in terms of the cost for families, is incalculable. So today we do seek to better understand, and today we seek to consider ways to address this very complex but very critical problem of high impact and great consequence. As Bill mentioned, I'm Mark Ginsberg. I'm Dean of our College of Education and Human Development. It's an honor to moderate the first panel, Magnitude and Scope of the Opioid Epidemic, Developing a Common Understanding. So joining me on the panel today, we have one substitute, Wilson Compton, from the National Institute of Drug Abuse, NIDA, at the National Institute of Health, will be our first speaker to talk about the federal perspective. Chris Jones, unfortunately, from the United States Public Health Service, was called to a meeting at the White House this morning and is unable to be here. Talking about the state perspective will be Hughes Melton, who is Deputy Commissioner for the Virginia Department of Health, and we're pleased that he's here. Talking about a regional perspective across the Northern Virginia region from the Prince William Health District, and chair of the Northern Virginia Regional Opioid Work Group is Phyllis Randall. Oh, I'm sorry, it's not Phyllis Randall, it's Allison Ansher, reading from my wrong script, sorry about that. Allison Ansher, Director of the Prince William Health District. And from a law enforcement perspective, I'm really pleased that Doug Poole is here, who is the Chief of Intelligence for the United States DEA. So we'll get started in just a moment, have my panel members join me, and we'll begin our first panel.
There we go. I'm loud and clear. Good morning. I am not Captain Chris Jones. I'm Wilson Compton from the National Institute on Drug Abuse. And while I'm sorry Chris isn't here, I wanted to take this opportunity to suggest that the fact that Chris called me as a substitute for him last night about 5 o'clock and let Dr. Hazel know speaks to the interagency collaboration when it comes to the federal response. That Dr. Jones from SAMHSA and I have worked together on the opioid issues for a number of years, and I think that's really important. It's all too often that each of us in our own area become, we're quite busy doing our own daily operations, and we forget to coordinate and collaborate across agencies. But we're very lucky that in the Department of Health and Human Services, we have a robust collaboration across the agencies. And indeed, it spans the federal government as we're working assiduously to make sure that we understand what each other is doing so that we can provide the resources to address this really national crisis. I have a handful of slides with you that I hope will show up. And actually, this is my, this is the wrong presentation. I have two, because I'll be back with you around 11:05, so hopefully they'll get the other one loaded in just a moment. What I want to tell you about, though, is why do we care about, there we go. Okay, now I'm on track. I love this slide. This is from our colleagues at the National Center for Health Statistics. And the reason I like it is because in a single graphic, you can immediately understand how this epidemic, how this crisis has spread all across our country. These are maps that use a heat-coded system, so you immediately recognize that red are the hot spots. And to me, I think that's important because it reminds us of the fire that's spreading across the country. And I think you recognize two things when you look at this map. One, every place is getting warm or hot from this overdose death issue that has claimed over 300,000 deaths. Each one of those people had a mother and a father, has neighbors, often have children, certainly have loved ones that care about them and represent the devastation that this causes, not just to the individuals who perish, but to all of the people around those individuals. It's an extraordinary situation. But I think what we see in this map is both that everywhere has seen a worsening of this crisis, but it's not evenly distributed. So how do we make sure that we respond to the hot spots with particular vigor? And that's always been a challenge when there's needs everywhere, but there are particular needs in specific locations. This is typical for drug abuse and drug addiction. These are conditions that are spread through social networks, through person-to-person transmission of behavior and issues. And so that's often why they happen in different areas in different ways. The numbers are extraordinary. While we see 63,000 overdose deaths in 2016, we estimate that there are over 40,000 due to the opioids. But I want to suggest to you that the opioids are not one category. And that's why I highlight for you that in some ways this is three intersecting epidemics. Dr. Hazel and the governor reminded us that this did start with overprescribing. That was the spark that started this fire. Through a really well-intentioned desire to treat pain more effectively. That is our goal. We need to make sure we do a good job of taking care of patients with pain. Unfortunately, we weren't sort of paying attention to the potential consequences of opioids, which have been recognized for centuries, but somehow we lost sight of that in our desire to address the untreated pain in so many people around our country. So we need to do a better job of that. But it's not just pain, it's sort of three intersecting epidemics. The exposure to opioids through pills set up a population who were at risk for transitioning to heroin. And not all of them, in fact, most of them don't make that transition, but enough do that we've seen a marked increase in heroin use and heroin overdose deaths in our country. Unfortunately, the availability of illicit fentanyl coming mostly from overseas, from China, and multiple factories where it was produced legally in many factories in China, a legal production in another country. So this reminds us that perhaps we need diplomatic efforts or international treaty efforts to help us. And indeed, we've seen some of that work so that it's now not legal to produce this in China. And we hope that that will begin to reduce the availability over time. But it really is three intersecting epidemics, and each one demands a somewhat different response. If I change prescribing patterns, I'm not going to change the availability of fentanyl in the illicit drug markets. So this is, unfortunately, with the evolution of this crisis, we've had to change gears and begin to think about multiple ways to address the problem. It's not just the death rates. I'll just remind you quickly that it's also infectious disease, and this is driven by sharing of injection equipment. So we have an outbreak of hepatitis C because this virus is spread even more readily than HIV. We saw the outbreak of HIV in Indiana, and unfortunately, the CDC estimates that there's some 200 counties at risk for a similar outbreak. When we think about the other key driver that we're paying attention to now is we know that we can treat people for opioid use disorder and reduce the number of people at risk for overdose by getting them into effective treatment. Unfortunately, we don't take advantage of that in many, many parts of the country. This is just an illustration of, on the left, there are well over 2 million people who have a significant opioid use disorder condition, addiction to opioids. Not too many of those are diagnosed, so a lot of people don't even recognize that they have a problem. How many are engaged in care? A surprisingly small number. And then how many actually stay in care for the length of time it takes to really help people enter recovery and turn their lives around? Unfortunately, that's a perishingly small number. So we have a long way to go to improve our system of care. And so I'm going to end by talking about, well, what are we doing about it at a federal level? Well, the department has a a multi-pronged effort. We, of course, focus on prevention by addressing prescribing patterns. We want to reduce the number of people entering this pathway. We want to improve the availability of universal prevention services. How many of you will know that we have middle school prevention interventions that have now been proven to reduce the onset of prescription drug misuse? I bet a lot of you don't know that. There are 3 studies that show that the Strengthening Families Program 10 to 14 can reduce the number of kids that will take up a prescription opioid misuse 8 or 9 years later. These middle school family-based interventions can provide a protective shield around youth and populations. That's really something that we haven't taken advantage of effectively around the country. What can we do to increase treatment availability? That's a major need. How can we save lives acutely? I can't do treatment or interventions or recovery services with a deceased person. So what can we do to make sure that we get Narcan out there, naloxone out there to save lives acutely, to make sure that we have the opportunity to help people turn their lives around? Will it work instantaneously? No. People don't change their behavior very readily. But I guarantee that that's a better alternative than the unfortunate deaths that we're seeing all too often. I'm really pleased that the department is also emphasizing improving the data systems. We have already seen that the mortality data are available more quickly. If you look on the CDC website, you can actually get data from just 6 or 7 months ago. It does take time for the medical examiners to finish their evaluation, to do the testing, and then get the data to their state and then to the CDC. But we now see it within a few months rather than the 2 or 3 years that was the case in very recent memory. We're also pleased that we see strengthening our research infrastructure as a major emphasis, both for the department, and I'm very pleased that Congress has been extraordinarily generous with the appropriation that they just made for this fiscal year that we're about halfway or more than halfway through. There was an increase of some $500 million for pain research and opioid addiction research as well. So we look forward to supporting that efforts. Chris wanted me to highlight a couple of areas where SAMHSA is providing support and some of the specific SAMHSA programs. I'm very pleased to let you all know that the second tranche of the state targeted response grants were issued yesterday. So your state coffers through block grant mechanisms have an increase. And so Virginia has the same amount of money they got last year to continue the efforts that were begun in 2017. But in addition, there was another $1 billion, so about a doubling of that amount that we had for this year that SAMHSA will be distributing through the increased allocation from the recent appropriation. There's also efforts in terms of specific medication-assisted treatment for the prescription drug issue. There's efforts around the drug-free community programs. That's a place that might implement some of those prevention activities I highlighted for you. Pregnant and postpartum grants. I haven't talked about the increasing neonatal absence. I'll do that in my next session when I see you after 11. And drug court efforts. These are just some of the ways that SAMHSA is providing the resources to you and to your state so that as George Mason thinks about how to organize, there may be some additional horsepower to help support those efforts. I will highlight for you that Dr. Jones is leading a new program at SAMHSA. The Policy Lab was initiated as part of the 21st Century Cures Act last year, and Dr. Jones is the initiator of that program, which is designed to bring evidence-based practices more into place. So how can we use the SAMHSA funding services to help make sure that we bring the most effective approaches out into the communities where we need them to have the biggest impact? And with that, I'll wrap up, and I look forward to some discussion. Thank you.
Thank you, Wilson. Thank you, Wilson. Our next speaker is Hugh Milton. Hugh is Deputy Commissioner of Health for the Commonwealth of Virginia. Hugh, thank you for joining us.
Thank you. So did anybody hear the NPR segment this morning on the addiction? Yeah, right? Very powerful. So multiply that story times 300,000 families and individuals, and you get a sense of what our communities are experiencing, what your community is experiencing. And so if you walk away with nothing from my time with you this morning, I want you to walk away with the concept of GO, which means when you're talking prevention, And when you're trying to get to a disease that is highly stigmatized and prevents people from seeking care, it gets in the way of that, you have to go to where they are, right? They typically will not come to our typical treatment locations. And so we'll get into that in a second. But if you forget everything else, it really shapes how do you reach out and make a difference in the individuals' lives who have the disease. So Governor Northam talked a little bit about our 2017 data. We just got it in 2 days ago, I think, from our Office of the Chief Medical Examiner. And you can see he mentioned a little over 1,200 deaths, right? That's just for opioids. So the total for all drug deaths was 1,534. And you can see that the year before that, large spike here, right? And then this past year, that 35% increase, this past year about an 8% increase. We had expected about a 12%, so we are glad that it was not that large, but still it's more, and plenty more work to be done. But that's the 30,000-foot view. And the reality is that on the ground in each individual community, it can look really different. So this is that slide you just saw, but county specific. And you can see some counties are very light colored, which means that they don't have as large of an issue in this area. Some counties are very dark, they have a major issue. And so what that means is when you come together to form a coalition in Northern Virginia or in Fairfax or in Prince William, you need to know what's going on specifically in your community. And not just how big the problem is when it comes to addiction, but the type of addiction that I'll get into in a second. And you're going to hear from my colleague, Dr. Ansher, that we have that data. And so make yourself familiar with it. So not only opioids are not opioids, right? Both in terms of how they work, but also which ones are causing a problem in your community. So the good news about this slide is that the carfentanyl that the governor referred to actually is causing fewer deaths. So we do have a graph where it's going down. There are a lot of reasons for that I don't have time to get into, but that's a little bit of a light in an otherwise cloudy story. But heroin continues to increase. Fentanyl continues to increase. Methamphetamine continues to increase. And so does cocaine. And I wanted to point out the methamphetamine and the cocaine aspect, of course, those are usually found along with another drug that the individual died from. But it tells you that there are other dynamics going on in the community, and you can't just approach it seeking to address the opioid component. You have to recognize that, well, there's a stimulant component as well. And they look very different. So this is the map for methamphetamine, more of an I-81, southwestern part of the state, which is where I live. Whereas cocaine is more of an I-95, eastern part of the state, right? So which community you're in, which county you're in, you need to understand. So this, I wanted to point out, the blue line is the overdose deaths from prescription opioids. So clearly we continue to work, and I think later on today you're going to see really some of the wonderful numbers of the success that we've had due to the work of the Department of Health Professions. Dr. Allison is here, and that has made a big difference in the prescribing pattern in the state, such that prescription opioid overdose deaths are relatively flat, whereas the majority of the increased deaths are coming from fentanyl and heroin. So that's the deaths. So how do we try to measure disease burden? And there are a lot of different ways to measure that. But one way to measure it is the ER volume. How many individuals are coming into the ER with an overdose? And so what the slide shows is blue is 2016, red is 2017, and gray is 2018. So overall, we've seen a downward trend in the number of ED presentations for overdose. And so if you sum all that up, if you sum the months up year to date, you can see that 2017 it was higher than 2016, but 2018 year to date is less. I think that's a good sign, right? But it looks different in different regions of the state, as you can imagine, right? So unfortunately, in the northern part of the state, this year's worse year to date than last year. In the eastern part of the state, in the Tidewater region, right, that looks pretty good. So again, it looks different based off of where you are. So I wanted to talk a little bit about sort of what we're doing. You heard the priorities from Governor Northam, and he mentioned limited resources, and the reality is that we do have limited resources in a lot of different areas, in particular workforce, right? So even if we could pour a lot of dollar resources into the different communities, it takes time to train people who can provide these services. And because of that reason, we really need to focus on where we seek to intervene. So the governor talked about prevention, treatment, and then harm reduction, or is what we call it in the health department, right? Recovery. It's called sort of different things depending on which group that you're talking to. And so when we're talking prevention, and we think about we need to go where the individuals who are at risk are, right? That's where we talk about trying to get into the schools to impact the youth. Last week I was at UVA and I went to the corner at 7:30 in the morning on Sunday to grab some coffee. Visiting my daughter, and I look up, and up the road comes 3 young male undergrads, right? Each with a case of beer under their arm, and puffing on a nicotine delivery device at 7:30 in the morning on a Sunday. I thought, well, there goes 3 of my future patients, right? I mean, and they will not seek treatment when they actually come down with the disease of addiction when they're out of college and trying to figure out what's going on when they're 26 years old. Right, and so we need to intervene while we have them in a location where we can get to them. For treatment, medication-assisted treatment works. It's a 50% recovery rate. When individuals get best practice care for a fatal disease, that's pretty good, right? But there are specific places where individuals are really, really high risk. And it's in those, what we call transitions. And so Governor Northam mentioned Chesterfield and the work that's going on in Fairfax, right? Are individuals who are incarcerated and then making that transition back out into the community really, really high risk. Not just high risk to begin using again, right? But also high risk for overdose deaths. And so targeting our efforts in that transition period is key. The other place would be in our ERs. When somebody comes into our ER with an overdose, they're extremely high risk to overdose again, and they should not leave the ER without having been started on medication-assisted treatment and plugged into a treatment program in the community. Of course, that's easier said than done. We have a limited treatment resources, but there's a lot of good examples, Maryland being one, where this is being done and it's very effective. And then the last would be harm reduction. So Dr. Compton mentioned hepatitis C and the consequences that come along from IV drug use. And syringe service programs work. And not only do they work to help to stop the spread of hepatitis C, but that's your highest risk population in the substance abuse population, right? And they will come for those services. And while they're there, you can engage them in discussions about treatment and the other types of things that they need. And so we're working hard in the health department with our other partners to get syringe service programs going. They do require jurisdictional leadership being on board, the law enforcement being on board, and the healthcare side being on board. So it's sort of a heavy lift for a community. I know there's active work being done in the Northern Virginia and the different jurisdictions to see about trying to offer these programs. And I encourage you that if you think they're not a good idea, to take a little extra time to educate yourself about really how effective are syringe service programs, because when they are done right, they make a difference.
Thank you very much.
Thanks.
Thank you, Dr. Melton. Our next speaker to talk about the regional perspective is Dr. Allison Ansher, who is the director of the Prince William Health District and also the chair of our Northern Virginia Regional Opioid Working Group. Dr. Ansher.
Hi, good morning. My PowerPoint's going to have a little different focus because when Dr. Hazel tells you to do something, you do it. My PowerPoint is going to have more of a focus on what's going on in the community. But as a public health professional, it's not that we condone people to use drugs. We understand they are going to use drugs. And so we need to face it and do things to decrease the possibility of them dying or developing a lifelong infectious disease. So that's a lot where public health comes from and supports the rest of our partners here. I'm going to give just a little bit of Northern Virginia data before I Well, I'll start on the data. Okay, in Northern Virginia, we're used to working as a region, particularly for emergency preparedness. And in fact, we're used to working with the National Capital Region, which is some of the counties in Maryland as well as DC, on a lot of initiatives. And in fact, we're working on this opioid epidemic with the National Capital Region too. In general, in Northern Virginia, over the last few years, our unintentional overdoses that go to the emergency room has remained at about 6 per 100,000. Although the number of ED visits have gradually increased over time, the ED visits for heroin overdoses over the last year has remained stable at about 1 per 100,000 and is the lowest in the state. Unfortunately, the number of ED visit overdoses has, though, increased from 2015 to 2016 to 2017. Prince William County, Prince William Health District, which includes Manassas City and Manassas Park, has the highest rate of heroin overdoses in the Northern Virginia region. Police reported suspected heroin and opioid overdoses have increased dramatically between 2013 and 2017, but we truly didn't begin counting until 2016. Although by observation, the police noticed a huge increase in 2015. In 2017, the 5 top substances submitted for analysis in our region were marijuana, cocaine, heroin, Xanax, fentanyl, in that order from most to least. But as Dr. Melton said, often people use more than one drug. The top synthetic drugs found and identified in Northern Virginia were fentanyl and methylfentanyl, heroin plus fentanyl, buprenorphine plus naloxone, and cocaine and fentanyl. Okay. All right. Well, from a regional perspective, what we did was initially we came together and kind of brainstormed as far as what in the region we felt was important. And this included advocates, police, state police, local police, Prevention Alliance, community service boards from the various 5 jurisdictions in Northern Virginia, public health, the hospitals. And after we brainstormed, we voted on what we thought was most important to initially start working on. So, of course, prevention through education was a top choice, and all the local communities have done. Oh, thank you. Thank you. All right. Got it. Okay. All the local communities have done a lot of local community education, both on a large scale, particularly in the school systems or through the school systems, as well as more intimate community education. Materials have been given to veterinarians regarding opioids because, believe it or not, people injure their pets just to obtain the opioids that would be given to their pet to alleviate pain. And many veterinarians may not have been aware of how they may accidentally feed into our opioid addiction problem. We've put together educational materials for HIV and hepatitis. The Prevention Alliance has worked with the school systems to get curriculums into their family life programs in the region, starting in the middle school as well as high school. Community education addressing stigma. I went to a community event for people who were released from the jail and needed to learn about community resources. We had the medication disposal bags, but they were afraid to take them because they felt that if they took them, it meant that they utilized drugs. So you can see how the stigma impacts the behavior. I think we need to do a better job with medication disposal bags, not just associating them with opioids, but also associating them with just the removal of unused medication, and they may be more acceptable to the public. Community education, COG, Metropolitan Council of Governments, we all share Northern Virginia with Maryland and DC, the same media market. We're working on stigma prevention PSAs for the different age groups that are impacted by this epidemic. Community education, the Revive program, which is a training to teach the public on how to utilize Narcan to save the lives of a loved one or someone in the community or someone in the workplace or someone in a shopping center, and educate about family resources. Many of you may not know. I know there's an issue of HIPAA, and there's some concerns when someone is overdosed about sharing information with perhaps family members or someone who have witnessed the overdose because of HIPAA, and the individual who's overdosed not giving you permission to do so. Police are not under HIPAA, so police can give out information to those that are around the person who overdosed without the person's permission, alleviating that issue of concern. So police are a huge partner in this, in the prevention and treatment and saving lives. The prescription drug monitoring program, we've actually, as it's changed and developed, we've had people involved in reviewing it, ensuring that there aren't bad practitioners, there aren't patients who are doctor shopping, have actually gone to various medical societies and explained the importance. It's not just to be annoying to practitioners, one more thing to do, how important it is to identify and help not only individuals who have an issue, but remove those bad practitioners or from continuing to prescribe opioids. In addition, we've utilized materials to educate dentists, and in the future, the dentists will also be required to take a prescribing education to obtain their license, like now clinicians are, in the other clinicians in the medical profession, as well as they will be required to enter information into the prescription drug monitoring program. We've seen an increase in the number of sites that have 24/7 medication collection sites. Loudoun Sheriff's offices, I believe they have at least 5. Manassas Park, a very small community, in their police station, they've chosen to do that. I believe Alexandria has chosen to increase the number. Walgreens now and CVS in the future will be having places where people can put their unused medications 24/7. The medication disposal bags we talked about, all the communities are distributing them. Thank you to the Virginia Department of Health and the Department of Behavioral Health Services from the state. Additionally, there's, I believe is it April 28th? Is all the hospitals are working with the police to have a cross the nation, dispose of your unused drugs event. People, we do focus on the young, but the people over 60, a lot of them have complicated medical conditions, taking lots of medications, and additionally have been given opioids for pain, and we're seeing addiction in our older residents as well as deaths. So we can't forget that they need education too. From the treatment perspective, there's been a lot of training to providers, but there still aren't enough providers. And when I look at George Mason, how George Mason can help benefit this epidemic, they are really great at providing workforce development. So I look forward to seeing how they develop new practitioners to help provide medication-assisted therapy across the Northern Virginia region. We wanted to investigate the potential to expand HIDA programs to more districts and look at something called Lily's Place in West Virginia that allows mother and newborn to remain together when the mother is being rehabilitated from drug use. Naloxone distribution and training is happening in all communities. As we mentioned, I see I'm running out of time, right? TB and HIV and hepatitis C education and treatment. We thought having peer groups help with recovery was important, and we're looking at best practices, as well as regionally developing the same materials to give to loved ones to help. Additionally, regionally, the Prevention Alliance is working together at a website that will have all resources for those who are at risk for overdose in one site that anybody can go to, from teachers to providers to law enforcement. And if they have treated somebody for an overdose with Narcan, they know that there's this one site where they can get the information. And I can go on, but I won't.
Thank you very much, Dr. Ansher. It's great to have the federal perspective to the state perspective and then hear about what's happening here in Northern Virginia. Now we'll hear about the law enforcement perspective from Doug Poole, who's the Chief of Intelligence for the Drug Enforcement Administration.
Yeah, not drug abuse.
No, not drug abuse, Drug Enforcement Administration, exactly.
Good morning.
Thank you, Doug.
Good morning, and thank you for allowing us to participate. It's great to be a part of this community. It's not one that normally DEA is involved with, but it's it's a place where we need to be. So, like my colleague, I listened to Dr. Hazel, and he had asked me to, although this is opioid, and that's the focus, and it should be, to talk about the other parts of the world, the other drugs, and what we're seeing there. So I'll focus on that initially. So the drug situation overall is not going to surprise anybody. CPDs, we've talked about that already. Fentanyl, heroin are the big threats, but there clearly are other threats, and the previous speaker talked about it in Virginia. Methamphetamine, it's actually not a new problem. It's a problem that's been here forever, and forever is a different term, I guess, but it hasn't gotten a lot of the press that probably it should have. And while primarily in the past it's been a problem out in the West, the Southwest, it is clearly coming across, and you saw it on the chart, the heat map that you had for Virginia. Virginia is not alone. Meth is a big problem, and it's one that's going to be here to stay. So that's one that we are continuing to focus on, especially with our state and local partners. Cocaine, if we went back to 2007, there was kind of a good success story for cocaine, working with our partners, Colombia, Mexico along the border, state and locals inside the country. The cocaine problem had leveled off at a fairly lower level. What we've seen over the past 10 years is that it's going to rebound. I'll talk a little bit more about that. The marijuana threat, I'm not really going to talk too much about that. I think everybody's aware there's a lot of flux going on, both in terms of federal, state, local legislations, all those things, and as that works itself out, we'll deal with it, but we still all have to deal with it now. And then new psychoactive substances, synthetics, the cannabinoids, the K2, the spice, those things are problems that are still there and we're still having to deal with. And I will end up a little bit to kind of set, at least a discussion point about the networks and the organizations that we have to talk about. So it's a busy kind of chart, but once you look at it and you understand what it is, it's a great picture of heroin and the cycles of heroin. This only goes back to 2000. If I went back to 1970s with this same chart, you would see that Over the time, the source of heroin in the United States has certainly fluctuated. Started out in Mexico, goes a little bit to Southeast Asia, Southwest Asia, comes into South America. What we're seeing now is that it's Mexico. And I will say we're very confident in our ability to say where this heroin is coming from. DEA does have a program that allows us to do what we call signature analysis, so we can take samples, and looking at both the plant side as well as the process side, we can tell you where that heroin was processed. We can also do the same thing for cocaine. So we're very comfortable now to be able to say that Mexico is the primary source of heroin for the United States, and that has been a bit of a change over the last few years. Part of that change may be that we are just better able to detect what it is, but clearly our big threat for heroin itself is coming from Mexico. Fentanyl, I'm not really going to talk too much about that because it's already been here. And meth, I will say a little bit more about meth. That again, it's a problem that's been around. It's starting to get a little more publication, I guess, or publicity, but it's one that's a real threat to the community. I'll quote a friend of mine from Georgia. He said, "Fentanyl will kill you very quickly. Meth will make you want to die." It's a very terrible drug with the community, and it's very, very difficult to deal with. Again, it's been in the West, it's been in the Southwest, but it's really coming across the country now. Again, as far as the source for methamphetamine, Mexico is the primary source for methamphetamine. It used to be that there were the little mom and pop, shake and bake labs that people would do in their homes. That's gone away. There's so much meth that can come across the border. It's cheaper. It's higher potency. As far as the organizations are concerned, it's an easier way to make money. Not to say you don't still have some lab sites, and that's what this map is actually showing. Again, a heat map where seizures we've made, whether it's labs, chemicals, cleanups, things like that. So it's still happening, but the greatest source of methamphetamine is coming across the border from Mexico. Cocaine, again, if we went back to 2007, beginning there, again, the supply dropped, the prices went up, all those indicators that showed that cocaine was leveling off as a problem. But what we've seen in the last few years is that cocaine is rebounding, and rebounding in a large way. One of the problems we have is our data, like other data, is older, so it's worse now than what you really see on the chart here. We just don't have the data to show it, but we know that it's coming there. And it's a factor of a lot of things. For the United States, the primary source of cocaine is Colombia. Peru and Bolivia are also the other countries that produce cocaine, but they are not targeting their cocaine to the United States. We don't see it. And again, we're comfortable saying that because of our ability to do the scientific analysis. In Colombia, there's been a decrease in eradication. There's been an increase in cultivation. All that cocaine has to go somewhere. The United States is still the largest market. It's not the only market, however. We see cocaine going around the world. If you look at prices, a kilogram of cocaine in the United States will cost $25,000, $30,000 on the street, give or take, depending on where you're at. You can go to Australia for that same kilo and get up to $200,000. So as a business model, the cartels, the drug organizations, they look for where the profits are. So there's markets around the world, but the United States is still a big market, and we are seeing a real rebound in cocaine. So that means you and the health and treatment communities are going to see it as well. The other thing that I wanted to talk about was Mexican TCOs, and or just the threat, the organizational threat to the United States. So for the drug threat, primarily it is Mexican drug-controlled organizations that are shipping the drugs in the United States. So again, the drugs are coming, whether it's heroin, or cocaine, or methamphetamine, or even marijuana, it's coming from the south. It's coming through Mexico. And those organizations are the ones that control the market in getting the drugs in the United States. And then they will make their partnerships for distribution once they get in the United States. And we clearly are seeing a lot of connections between the cartels and the gangs. Not so much in terms of a specific gang works for a specific cartel, but a specific gang will work who they need to work with in order to make money and continue to push their own goals. But there is a lot of connection between the drugs and the gangs in the United States. That's the traditional. Fentanyl is a little different because fentanyl is kind of a unique drug. It's, again, most of it is coming from China. And it's coming either directly to the United States, whether it's mail service or other kind of deliveries, comes into Canada and then comes down, may go into Mexico and then comes up. But because the way fentanyl can be obtained is through the web, especially, open web, darknet web, you're not seeing the organization structures like we see in cocaine and methamphetamine. So it's a little different as to how we can target. Not to say there are not big organizations trafficking fentanyl, but it's a bit of a different process that we're dealing with. So that's, I'll leave that, but a couple of things just as kind of what we're trying to do differently in terms of how to address this. The first, I think, and this is kind of a real good example, is just sharing information. We have a lot of information in DEA that is of value to other law enforcement agencies, and we're pretty good at that, sharing with law enforcement. We need to get better at being able to share with the community partners, and we're trying to do that. The slides I just showed you, they actually come from what we call our National Drug Threat Assessment. We are required to produce that on a yearly basis. This past year, 2017, was the first year when we've done it as an unclassified product. It's not marked as law enforcement sensitive, it's not secret, any of that, and we did that just so we could get it out. You can go into DEA.gov and you will find it there. I actually brought copies with me if anybody wants one. The new version will come out in October. That's when we schedule to put out the new threat assessment every year. The other thing that we've done is we have written a lot, we're writing a lot more to release to the broader community. So on the intelligence side of the house, we're writing a lot of our products so they're not marked at all, and they're able to go out to the world, posted on DEA.gov, and so we can use that as a way to help inform our partners in the community as to what's going to happen, what's coming on. If we see a new drug or if we see something that's different, it gives us a chance to get it out very quickly. So we're really pushing to do that. We're working more with our non-traditional partners. Not too long ago, we actually did a personnel exchange between CDC and DEA. We had somebody down at CDC. They put somebody in our office here at headquarters. Never would we have thought, to do that. But it's very important that we're able to do it, and there was a lot of benefit. They were able to get data from us that they wouldn't have seen before and put it across data that they had and come out with products that were helpful. We issued a joint health safety alert between DEA and CDC, something that wouldn't have happened in the past. So I think there's a lot of good things on that side that are taking place. We need to continue to expand our work with our state and local partners, and I look at the sheriff, and I know we work very well in lots of different categories or ways, whether it's a drug task force. The HIDA programs are huge partners with us. We need to continue to do that. We also work with foreign partners. DEA, small agency, but we're the largest federal law enforcement presence overseas. About 10% of our people are overseas at any one time. We're in over 65 countries with 85 offices, and so we have to work with our partners to try to help stop it at the source. Those partners include Mexico, Colombia, but also China. Mentioned earlier about the ability to, if we could do something with Chinese production of fentanyl, that makes a difference. We actually met with China, it was probably a couple of years ago. Right after we had that meeting, they scheduled fentanyl and about 105 other compounds, and immediately we saw a decrease in fentanyl shipments coming in. The problem was we saw an increase in all these other analogs that come right up. So, but again, we're able to have some impact, and we'll continue to do that. And then we obviously do things like Take Back. We sponsored the National Take Back and try to help push the word out. And we're, again, working with our state and local partners to do that. And then we've instituted a program we call Operation 360, where we will target very hard-hit communities, and we've done it now in about 10 communities across the country. And we can go in and we can look from the enforcement side of the house to take out the people that are threatening the community. But we also need, and this is what we're doing now, is working with our community partners to make sure they can come in and fill the gap. So if we're going to take the people out, somebody has to be there to go in and step in and make sure the community resources are there, or else the problem will just come right back. So we're approaching things in that way. So we're looking at new and different ways that we can work with the community and help bring some solution to this process and this crisis. So with that, thank you very much.
Thank you.
Thank you. Thanks to all of our panelists. We have just a few moments for a few questions, Bill. About 5 minutes?
An introduction. Doug mentioned HIDA, the high-intensity drug trafficking area. Tom Carr runs the Baltimore, Washington high-intensity drug trafficking agency. His agency has a big presence here at the Mason campus, so if you're interested in the work that they do, I just wanted to point him out. And one of the problems you get into when you start introducing people is you don't know who all is there. And one of the failures of my day this morning is I didn't recognize that Supervisor Pat Harity was in the audience, and he is in the back here. Where'd Pat go? He has to leave at some point, but I wanted to be sure that he was recognized.
Great, thanks, Bill.
So take about 10
Thank
minutes.
you. Yeah. Well, a terrific panel to set the context, to set the stage, to tell us more about the problem, and to help us to understand the prevalence of the challenge. Let's open it up to a couple of questions. Have 5-10 minutes for that. Microphones in the front. A couple of brave people coming forward, please.
Hello, my name's Lee. I work with the Inova Juniper program, which is the outpatient HIV services of Inova. I wanted to ask Dr. Ansher if there are ways for organizations, entities, individuals to get involved with the opioid working group that you chair.
Yeah, you just give me your name and I'll put you on the list, and we have plenty of work to assign you.
Great, thanks for the question. Yes, please.
About the statistics and what everybody's trying to do, but as a street-level practitioner, I've worked with a program of assertive community treatment and intensive community treatment. We take the services to the client, mental health, substance abuse. Big thing is, I don't want help yet. I've worked with people a couple of years, alcoholic, for example. I'm not ready. I'm like, you ready for detox? No, not ready. So that's what we deal with. I'm sure everybody knows it's the stupidest thing to say, but that's what we're dealing with. So that initiating and maintaining, I'm going to be on that panel. So that's a great place to be. And we talked about going to the people. So I just want to stress that is highly important, and then let's just get out there. So I want to plug that. Okay.
Okay. Any comments in return?
I want to comment on that.
Please.
I'm really appreciative that you actually are doing the community outreach, because while people say they're not ready, and that's not an atypical issue for persons with addiction, there might be something that they're interested in that you can provide. Maybe you can use that as an opportunity to provide them with naloxone so that they can save somebody else's life. And it's a visual reminder of the life-threatening nature of this condition. Also, when they are ready, we need to make sure that there are services available to them, because all too often we see when people are somewhat ready, I got no place to send them. And that's a major gap.
Dr. Melton, you make comments as well?
And I would just build on that Dr. Compton mentioned. That's why the governor mentioned same-day access. You know what, in my experience treating patients with addiction is there are brief windows where they will entertain the idea and a further discussion for treatment. And so when that window opens, you better be ready to provide the individual services, just like Dr. Compton was saying.
Okay, I think you're up next.
Susan Leidick, Advisory Board for College Health and Human Services here at George Mason. This is a question for Doug Poole. Last week or so on C-SPAN, I saw an Energy and Commerce Committee hearing chaired by Representative Greg Walden. He had Pablo Escobar and Steve Murphy, I believe previous DEA agents, talking about the collaboration they did between our own DEA and the Colombians and how important that was. I was very surprised because all we hear is about corruption in other countries, and that he was talking about just how critical that was. And if you could speak to whether that's continuing, that level of collaboration with the Colombian
okay, thank you.
Authorities.
Doug?
No, and thank you very much. And I will say, just Steve Murphy, he is former DEA, and he's actually a Northern Virginia native. He's also a star of Narcos, but that's different. But no, the collaboration is still very important. Just like we can't do what we do here in the United States without working with our state and local partners, we have over 1,600 task forces around the country. We have to do the same thing overseas. Colombia is a very big partner. And continues to be. We meet with them all the time. One of our largest overseas offices is in Colombia. But not just Colombia. Mexico is a big partner as well. And while there are corruption issues around the world that we all have to deal with, we have very trusted partners. We were able to establish those relationships. We couldn't have caught Chapo without the Mexican government helping, and CMAR especially. So that it's there, it's around the world. That's why we are where we are, and again, we're the largest U.S. law enforcement presence overseas, because we have to work with our partners.
Thanks, Doug.
Thank you. 2
very brief questions and very brief answers, then we'll have to stop. Yes?
I have a brief question. My name's Barry Byer. I'm Vice President of the McLean Rotary Club and a medical doctor. And there's a lot of interest in the Rotary Club, which is a service organization. We're local, regional, national, international, in the opioid crisis. So I'm here asking, what can we do as a service organization?
Great. Brief answers, yes.
Yeah, so Dr. Bill Hazel mentioned the concept of collective impact earlier, right? And what that requires is a broad cross-section of stakeholders to get engaged. And that includes Rotary, Lions, banks, health system, across the board. And so I would recommend that you find the local coalition. I'd say probably Dr. Ansher can plug you into the local coalition. There's definitely a place for Rotary. In fact, when I was in Atlanta at the summit, one of the states was talking about the partnership that they'd had with Rotary that was very successful.
Great, the Virginia Department of Health is a good place to start with some of that. Last question, yes.
Hi, my name is Lee Boswell, and I'm a retired Fairfax County firefighter and a suicide prevention activist with the American Foundation for Suicide Prevention. And thank you so much for inviting me to be here. I probably have the least amount of initials behind my name of anybody in this room, so I'm humbled to be here. But my question is this. If someone were to have a heart attack right now, there's an AED in this building. If a fire starts, there's a fire extinguisher. What type of timeline do you predict where we will have Narcan available, particularly like in malls, people where we have concentrated numbers of people? What type of timeline do you see for that evolving?
Good question around accessibility. Go ahead. Who wants to take that one on?
Well, I'll start. Clearly, this is both this is a joint federal, state, local issue because these are systems that exist across all levels of our community. We just saw the Surgeon General issue an encouragement to every citizen to participate in saving lives by having Narcan readily available, whether that's on their person or in public places as you're describing. We don't know exactly what the best model for distribution is, certainly starting with first responders, particularly law enforcement, who are typically the first person on a scene before emergency medical personnel arrive. So that's a starting point, but we haven't figured out exactly how far that should go. But certainly, as you're describing, that's an issue that resonates for all of us, and we'll look for opportunities to make sure that it is available. The library in Philadelphia is an example of where I didn't think of a public library as a place that needed this, because homeless use the public library, have a high rate of opioid misuse. They had a bunch of overdoses there, so this was an unexpected location where we had to have that available.
Great, thanks so much. Unfortunately, we're out of time. I want to thank our panelists. Terrific way to start the day. Look forward to continued conversation. I think we have a very short break just to bring the next panel up. Bill? Nope. Another change in plans. Secretary Hazel, you're in charge.
Thank you.
All right.
Thank you.
Thank you, Bill.
Thank you all very much. Thank you, panel. Did anybody learn anything here this morning? Good. Thank you. So, as an indication of the importance of this topic, President Cabrera and I and Carrie Bolognese, our Washington staff, were on Capitol Hill a couple weeks ago, and a couple of the Congress people said, we want to come and say a few words. And the first of those to come to say a few words, are you ready, is Congresswoman Barbara Comstock. And Congresswoman Comstock, I've known from her work in the General Assembly back when I first went to Richmond in 2010, and she's always had an interest in addiction and the opioid epidemic. She's had numerous town halls and meetings. She is on the bipartisan task force to combat the heroin epidemic in the U.S. House of Representatives. And for those of you at the university, I need to point out that she is also, got to find the correct title, chairwoman of the Research and Technology Subcommittee in the House, and on the House Transportation Committee. For anybody who had trouble getting here this morning, you know, we had that. I could talk for a good bit about Barbara, but the most important thing to know is that she is a patriot parent. Her daughter has a master's degree from Mason. Congresswoman, welcome. Thank you for coming by.
Well, good morning. It is wonderful to be with you to talk about this important topic, and really appreciate that you're holding this symposium and focused on this important issue that really touches every aspect of of our communities. This is not a red or blue issue. This is a human issue. It's a healthcare issue. It's a business issue. as I go around and visit businesses, inevitably, we'll talk about the tax bill and how that's been good for their businesses. We'll talk about workforce development. Inevitably, we slide into the issue of addiction, opioid addiction, all different addictions, heroin, and the problem. I was at a auto body shop recently, talking to him, somebody who I periodically go through and talk to their employees. And he had somebody overdose in their business just that past week. In the bathroom, they just found him. He had overdosed. Fortunately, he survived, but they had no idea that he had the problem. And then a second employee, they got a phone call from the dad on Monday saying he had died over the weekend on an overdose. So 2 people in a relatively small business. And then I had a gentleman earlier this week who came into my office, and he had pictures of his 30-year-old daughter. His daughter was my daughter's age. He had these beautiful pictures of a beautiful young daughter who had been doing well, had everything going for her, just bought a dog, a few weeks beforehand, but she broke up with her boyfriend. She went over to a friend's house. Unfortunately, that friend happened to have a boyfriend who was addicted to heroin, doing heroin. She's kind of down that day. Hey, we're going to go down. Hey, try some of this. And on the first time she tried this, she died. So here you had this beautiful young girl, just one mistake, one bad night, and unfortunately had friends that let that happen. So these are really tough issues that we are dealing with everywhere. But I am so happy you're doing this, and for you to know that there are important faces of recovery here. And I wanted to note 2 that are here today that I think are wonderful faces of recovery for us. My friend Nick Yakub, thank you, Nick, is back here. For those of you who don't know Nick, he actually went to high school with my daughter, and he unfortunately, at Langley High School, as he's told people, he got addicted to heroin then. He is 8-9 years in recovery. 10, woo! And what Nick talks about that I think is so important is for us to see the faces of recovery. As you're dealing with people with addiction, it is very hard for them to imagine a life without whatever they become addicted to, that life won't be the same. And Nick has a wonderful story to tell and has, really shown that face that is really what we need to see more of. And I know we've talked, when we've gotten together with our ONDCP colleagues, we really emphasize how important it is that we show the faces of recovery. When you're going through this, you have to see that light at the end of the tunnel. And Nick is that light at the end of the tunnel. Similarly, Katrina King, who is here, who I just met more recently when she was at a Prince William event, and she was sharing her story about her battle with addiction and coming out through that, dealing with her daughter. And if you haven't talked to Katrina and aren't familiar, Chasing the Dragon, and the movie that has been about what she has battled with, she is another brave person like Nick who comes out and talks about this, because not everyone can do this. Not every family can go out and talk about this. Not every family can come in and talk about how this has impacted them. But the more we get that out there, the more we have a community of support, and they see that this is happening to our friends and our family. This is something that is touching every demographic and every family in some way. And once we understand that, we can integrate the addiction treatment in every aspect of our life, with our businesses, with our faith community, a great wraparound place for our faith community to be engaged. And of course, what we're doing here and with the government. Despite the divisiveness that we unfortunately face and see every day, in our politics, this is an issue where I can assure you we are united. When the White House declared the opioid epidemic, a national emergency, it was people from all over the country, and I think it was pretty much politically half and half. And it was everyone sitting next to each other, you know, it was wonderful. You don't see that every day, but on this issue, that was the case. And so I really appreciate that the president made that a national emergency, as well as I know Virginia State Health Commissioner has also declared this a public health emergency. And with the number of people who've died of a drug overdose now exceeding traffic accidents, I know so many of you know, we really need to treat it as such. We did pass landmark legislation in the last Congress, but we're not stopping there. In the latest government funding bill, Congress allocated $4 billion in additional funding to combat the opioid crisis. This includes robust funding for addiction treatment and prevention, as well as law enforcement programs that stop the spread of the drugs and help families and communities get the assistance they need. But we have to make sure the resources are getting to our communities first and foremost, you know, to prevent and educate so that families understand, like this poor girl who never had touched something like heroin before, just happened to be at the wrong place at the wrong time in a bad, you know, just having a bad day. And that is a real bad day, and understanding that you cannot deal with this. You don't know what you're dealing with. Her addicted friends had a far different level of dosage. We know when people get in recovery, and then the easiest time to slip is when they get out, go back to what they were doing, and that's what kills them. So we have to have that constant education. Just last night, I'm thrilled that we heard about Health and Human Services announcing that Virginia will receive another $9.7 million in opioid state targeted response grants. They were created in the 21st Century Cures Act, which I was happy to co-sponsor, and so that money will be coming forward too. That's the pre-money. Now we still have the $4 billion that's going to start coming out too. For HHS, the grantees have used first-year funding to implement effective medication-assisted treatment, promote the use of naloxone and key prevention strategies, and build sustainable systems of recovery support services across the country. Prevention efforts include communications campaigns, along with use of proven community-based strategies. And I can't emphasize enough how important it is that we are working together as a community. That's why it is so wonderful what you're doing here at George Mason, because you have that outreach into all aspects of the community. The health community, you know, Inova has been working so well, and that's another area I'd certainly like to, you know, hats off to Inova for their work that they're doing. Last year when we had a roundtable in Loudoun, we had Dr. Samir Mehta from Inova talk about how they were, emergency personnel were working closely with all the hospital departments and across the system to adopt a standardized approach to treating pain that reduced opioid use both in the emergency setting and after a patient is discharged and deters opioid addiction. That initiative has resulted in an 83% reduction in the use of opioids. How wonderful that is. And I could see that my mother just recently had a knee replacement surgery. And you can see from the front end of when she went through that, through the back end, how everything they were doing was really designed to minimize the use of opioids. They had a shot that they gave her during the surgery that sort of kept the pain for the first 3 days, although it wore off a little early, but that way she didn't have to take pills for the first few days. Then, you know, they gave her much shorter, you know, they didn't give her a month's worth of opioids, it was just a few days. So, and then they switched her to Tylenol after that and really tried to reduce the use of opioids, and we're seeing that all the time. You know, the opioid reduction initiative involves, you know, educating hospital personnel, monitoring the opioid prescriptions through a state database, educating patients and families about their options. This was something where they were talking to my mom beforehand, you know, my dad who was going to be with her, so this was a real education effort, and then providing a continuum of care to resolve each patient's pain issues, because obviously we don't want this reduction to coincide with an increase in pain. We want this to be managed in a way that you're still dealing with things appropriately. So we really appreciate what Inova's been doing, and then as I'm happy to serve as a member on the Bipartisan Heroin Task Force, where we introduced the Better Pain Management Through Better Data Act last week. And this bill will facilitate better clinical data on non-opioid alternatives like this, so doctors have more prescribing options and fewer opioids are prescribed, lowering the rate of addiction. I should also note that NIH, which we have in the recent funding bill, also increased their funding substantially. One of the things that they are working on developing, which is really exciting, is a non-opioid painkiller. How wonderful would that be? And we are going to see that, I am confident, in our lifetime, and that will make a big difference. The task force is also working on a number of issues, such as the Interdict Act, which is legislation was already signed into law, which provides portable screening devices for the Customs and Border Protection to prevent, detect, and interdict fentanyl and other harmful narcotics at points of entry into the U.S. I know you've already discussed that today, but the fentanyl is just what is so highly dangerous. Like with this young woman, they're still going, who died on her first use, they're still trying to figure out what it was because it was so recent that killed her, but inevitably fentanyl is what we're seeing often is the deadliest thing that we're trying to battle. It is also a threat to the police. I mean, they have to now carry naloxone to use for them because if they get exposed to it, it's so dangerous. The Synthetic Drug Awareness Act, which legislation requires the U.S. Surgeon General to report to Congress on the usage of synthetic marijuana known as spice and synthetic amphetamines known as bath salts. So we want to increase knowledge about that. The Veterans Treatment Court Improvement Act of 2017 will increase the number of veteran justice outreach specialists that help guide veterans through veteran treatment courts. These courts will help put veterans who are in need of a path towards sobriety and a better life, have a better outcome there. So this fight, as you know, is going to be a multi-pronged community effort. So I can't thank you enough for being engaged and involved, and we have to, keep getting the word out. Do we have some press here too, I hope? Some press here? Yeah, they bring them in. Good. We hope they're... Because this is something where we beg the press to come and tell the stories, not to tell my story, but to tell Nick's story, to tell Katrina's story, to put faces on this problem of addiction, to have people understand this is right in their own schools, this is right in their own communities. My sister is a guidance counselor in Fairfax County, and there's so often it's not happening in our communities. That doesn't happen in our schools. It is happening in every one of our schools, and it's happening in our jobs, and we need to know, and we need to put that word out, that we're here as a community of support, that you can find somebody in your workplace or at your church or at your school who will reach out and help you, because that's the only way we're going to battle this, and we have put out these resources everywhere so we can do that. So thank you for being part of that community that cares. We appreciate all you're doing. And thank you, I'm very negligent in not thanking our great Dr. Hazel, who was wonderful to work with in Richmond when I was there. And we're happy to have you back here in Fairfax County and have you as a constant resource for us in all kinds of areas with Inova. So thank you for all you're doing here today. Thanks.
Okay, you all have been most patient with our schedule changes. I think we'll make an executive decision here and give you 15 minutes to break. Whoa, don't get up yet, sir. Whoa. About 15 minutes. What we'll do is we will move everything back and we'll shorten up the public comment time. So if you want to make comments, please help by making them brief. Now, a couple of things. We did make an effort. We do have members of the recovery community here. If you care to identify yourselves, just stand up so people recognize you or raise your hand. There are a few of you around back here. We thought it was really important that these folks be here. We don't talk about them without them, is the way it works. Other things I want to say, the hospitals, of course, you mentioned Inova, but we have representatives from Virginia Hospital Center, Centera, and HCA here. Having one system alone work doesn't get it done. It's got to be done jointly. This stuff doesn't respect geopolitical boundaries, and we've had a Republican Congresswoman, Democrat Jerry Connolly is going to come a little bit later and speak to us. Supervisor Randall and Supervisor Bulova are both Democrats. Supervisor Harris is a Republican. We have to figure this out together. So with that, meet the people around. That's a big part of this day. We'll see you in 15 minutes. Thank you.
All right, I've been told to call the group to order. The next panel is going to be starting in just a moment. All right. Sorry to break up your nice conversations.
I am not using slides.
Hi, Lori.
Okay.
Mark
Lori,
Roselle.
Nice to meet you. Great.
Nice to meet
Just
you.
don't worry about my slides. I
Okay.
didn't want any.
Okay. I'm just letting other people control the technology. So. Okay, thank you, everybody. We're going to get started in just a moment. All right, everybody, we're going to get started. Thank you. Our panel is all together. My name is Mark Roselle. I serve as Dean of the Schar School of Policy and Government here at George Mason University. We're located here in Fairfax and also in Arlington. I remember we had a really nice discussion with the university leadership back in October at the Homestead talking about the opioid crisis. My good colleague Louise Shelley, who is the director of our Center for Transnational Crime and Corruption, was there, and we had a very engaged, interesting discussion about this issue and what role the university ultimately could play. I'm not sure that's exactly the place where all of this got started, but you know, it was certainly an event that precipitated a lot of thought and interest in moving forward in this area, and it's just amazing to see it having come to this. So thank you all for coming. I think you probably know the Schar School is one of 10 colleges or schools of the university. And by the way, public service announcement, if you're interested, we have an event in Arlington tonight with the Solidarity leader and former president of Poland, Lech Walesa. I just noticed that we have about 230 people signed up for the event. We have seating for about 300. So if you go on Eventbrite or look at our website, you want to go hear Lech Walesa tonight, please look us up and do that. My role here is to moderate this distinguished panel. I will quickly introduce each one of them, and each of them will speak for between, I am told, 5 and 7 minutes, maybe a little bit of fudge factor there. But although this is on the program for 1 hour and 15 minutes, I am instructed that we're going to try to keep it to 1 hour, so the panelists will have to be very efficient here in presenting their comments and then leave some time for questions and answers at the end. So the panelists in order are Wilson Compton, who is Deputy Director of the National Institute on Drug Abuse, National Institute of Health, Loring Flint, Executive Vice President and Chief Medical Officer at Innova, Alexandra Duncan, the Substance Abuse Prevention and Treatment Initiative at the Pew Charitable Trust, Phyllis Randall, Chair of the Board of Supervisors, Loudoun County, and Brian Moran, second-term Secretary of Public Safety and Homeland Security. And we will go in that order. The first speaker is Wilson Compton. Wilson?
Put a timer up here so I try to stay on track and keep us on target. Well, it's a pleasure to be here today, and having seen you just a few minutes ago, it's still a pleasure to be here. I have a little different message for this panel, which is to focus on how science can be a solution for this crisis. Now, I hope it was a little bit implicit in how the federal response is being organized, but because there are two aspects of science. One is what are some of the basic solutions and basic information that can drive transformations in this field. We always want those. You know, we want the cure for cancer. We want brand new pain medications that are potent analgesics but are non-opioids and don't have the devastating side effects. Those are few and far between. They do occur, and with investment, they will occur. But we also need to make sure that the technologies that we know work are implemented on a widespread basis. And that includes science as well, testing different models for implementation. And I'll show you a couple of examples of each one of these. First off, I want to start out with one of the key themes, which is how do we save lives acutely? And I'm very pleased that the National Institute on Drug Abuse partnered with industry to help develop a new formulation of naloxone. A nasal spray formulation was developed in collaboration with the National Institutes of Health. We also, I'm thrilled that the auto-injector, the Evzio device, was developed here in Virginia. So we have two new examples that allow non-professionals, non-health professionals to administer this medication. I don't know what the big deal was about using a syringe and a vial, but many people were dismayed by that possibility. So a nasal spray and an auto-injector is a wonderful addition to our armamentarium. We just saw the Surgeon General of the US highlight for us the need for making these more widely available, and we had a chance to discuss that a little bit earlier. So what are some of the research needs? Well, fentanyl is particularly potent. We see that increasing dosages of naloxone may be required to save a life when somebody's overdosed with fentanyl. Might there be other medications that could be more useful or opportunities? Are there devices that could help save lives? Are there other ways to stimulate breathing? That's what kills people is they stop breathing. Other devices might help us for other overdose situations. This is lightning round, so we're going to switch gears pretty fast. I highlighted for you the importance of infectious disease, and I just want to mention to you that we've launched a collaborative research program with SAMHSA, the CDC, and the Appalachian Regional Commission. That's normally an economic development group, but because of the intersection of health and economic development, they're co-funding this research, this health research program to figure out how do we effectively and efficiently bring services to address the opioid crisis to rural areas. Not an easy task when the resources are few and far between. When we think about the exposure to opioids by pregnant women, we've seen a marked increase in neonatal abstinence syndrome, where this is extraordinarily common in some locations around the country. Some newborn delivery centers in West Virginia, in New Hampshire, and other settings see about 10% or more of the births in their delivery center are opioid exposed and have significant withdrawal symptoms. This represents a marked increase in costs. Some of what NIH is doing is develop better treatments or new treatments so that we can more effectively address the acute needs of these infants, but we also need to be thinking long-term about what are the models to support the mothers 3 weeks or 6 months later when they may be struggling with opioid addiction and need the resources and that we heard, at least I heard an ACT model earlier, that might be one approach to taking care of these these complex patients. Now, I highlighted for you the importance of prevention, and this is an example that I mentioned verbally earlier, where we now have 3 studies that show the potential value of a family-based support program for middle school kids. They don't really focus on prescription opioids. What they do focus on primarily are a bit about drug education, but mostly it's around strengthening families in terms of their ability to provide the 2 key issues when you're taking care of a 12 and 13-year-old. How do you provide love and nurturance without strangling them or doing things that you're often inspired to do with a 13-year-old? And how do you provide appropriate levels of supervision? I think this is a challenge for parents of all ages, but the pubertal adolescent transition is, of course, a notorious period for parents struggling. All parents can benefit from this, but particularly those at risk may benefit even more. What's surprising is, and I think a good observation is we see this program showing benefits many years later in terms of a protective shield. These kids aren't taking up prescription opioids as much. Many of them still are. This isn't a panacea, but it's one tool in our armamentarium. Now, I'm going to focus towards the end on improving addiction treatment. What are some of the models? We think we can get buprenorphine, so bring medication-assisted treatment into emergency departments so that when people come in with an opioid problem, they may be able to start treatment on the spot. We've seen similar issues when it comes to providing treatment in criminal justice settings, how valuable that can be to change the long-term outcomes. I'm racing through this. If you have questions, you can ask me. We've been doing head-to-head comparisons of the different treatments. One of the interesting things is once you get people stably on Vivitrol, it actually works just as well as buprenorphine. That was a real question for the field. But it's hard to get people to start on it. But it at least tells us that we know more about how to decide which sort of treatment people ought to get. There's a brand new treatment that was just recommended. This is not available yet, but a new medication for opioid withdrawal that may help physicians treat their patients who suffer withdrawal syndromes, that we hope will be available if the FDA is able to review the data and doesn't find any problems with the data that's submitted by the company that supports that. Now, the last thing I want to mention to you is a broad-based NIH initiative that Dr. Collins announced. And the vehicle for this is the terrific support from Congress in the form of $500 million of increased funding to the NIH specifically for the opioid crisis. It really addresses 2 key areas. One relates to developing better pain treatments. First off, understanding chronic pain and figuring out from a basic perspective how we can develop better approaches to treat pain without relying on opioids, which have such a notorious set of problems. The second area that, of course, is what I'm focusing on personally, because I'm from the National Institute on Drug Abuse, is how do we improve overdose treatment and addiction treatment itself. And we look forward to figuring out how to allocate these resources to do the best job of protecting our community and providing the answers in the long run. That's what we do with the NIH, and we're glad to be talking to you about our efforts. Thanks a lot.
Good morning, everybody. It's kind of hard to follow in a panel when a lot of what's been discussed already nationally is the same thing that is challenging us locally. And when we've educated our Congresswoman, about 2 minutes of my talk related to what the ED has been doing, which she obviously heard and did so eloquently. I guess what I'm saying is it's great to know that the message is getting out and that we are all swimming in the same swim lanes, but probably at different speed. I took the approach today, I'm not going to use any slides, but with that, really just looking at a number of frameworks. What should a health system be doing? And critically looking at where are we today at Inova and what else could we be doing as it relates to addressing this as a real crisis. And I question how many think we are really dealing with this as a real crisis. And hopefully my thoughts and comments will lead to the fact that this has to not be business as usual. So at Inova, we've had longstanding comprehensive addiction treatment programs. We have an inpatient program, we have partial hospitalization, we have intensive outpatient, we have Suboxone outpatient clinics as well. So we have had for a number of years those types of services. When Maria, who's in the room, want to wave your hand, and I were talking a year ago and created an opioid task force, one of the things that was very interesting to the number of people internally at Inova was they said, Maria, we need an hour of your time. We don't know anything about these services. So I think these services have been longstanding, been there for a while, but our own internal audiences needed better communication, understanding as to what's going on as a particular piece around how do we keep these services not secretive, but how do we make sure people optimally utilize them as a particular piece. Our focus has really been in treatment, clinician education. You heard about the great work going on in the ED, and the Dilaudid Light program, LITE, basically has totally transformed the way that we've taken care of patients in our ED. The numbers are real, not just it started in Alexandria, but in all 5 of our hospitals, 75 to 80% decrease in the number of people given Dilaudid in the ED. More exciting, 66% decrease of people leaving the ED with prescriptions, and the number of pills, which was mentioned, we've cut that down by 2/3. So people are getting prescriptions of 8 to 10 rather than 50 or 60, or in my days when I was providing care in a community health center, particularly folks with chronic pain, most of us didn't think twice about giving people a prescription for 100 oxycodone and come back in 3 months. And that was commonly accepted in the late 90s, early 2000s as the way to take care of what back then was the 5th vital sign, take care of pain. So with that, it really, a number of initiatives saying pain is the most important thing you should be doing. And I think out of ignorance, not out of intent, most of the clinicians who were practicing at the time probably had 1 or 2 patients, if not more, that they inadvertently created a crisis in addiction by really taking care of their pain. So we've done a lot of work on what we're doing in the ED. We've taken that work to care coordination. If we're controlling pain in a particular pathway, we transcend that into the hospital as well and going forward. And all of our outpatient facilities with the medical group, we have contracts. Anyone who's on a chronic pain for more than 30 days, the patients and the provider sign a contract. And what that means is I'm only going to get my prescriptions from one provider. If I get them from somewhere else, basically that means you're discharged from the practice. So it really is a way to stop the doctor shopping, stop going to the newest doctor in town, and the biggest frustration with new doctors is the first group of patients they get are the drug-seeking patients, which is kind of a unique phenomenon, but they're shopping. Who's going to give me my medicines? Trying to control that in the outpatient setting. We've had moderate success as it relates to using these types of contracts. In a smaller community, we had all the community EDs using the same contract and sharing the information. We even had a problem that we put on the problem list called on contract. It was a way to talk to everybody that this person has a substance abuse problem, that indeed it's not something to be embarrassed about, but something to help them on the way of not making it too easy to get prescriptions. So a lot of work we've done on that, using that as a framework. We are looking at a number of alternatives to opioids as it relates to pain management. Early recovery after surgery, ERAS, has been very revolutionary as a way to control pain with different modalities, COX inhibitors. We're doing some therapeutic talks, some yoga in preparation, as well as simple as high-dose Tylenol right before surgery, not necessarily IV, as a way to control the pain during surgery. So a lot of work is being done there. And Dr. Hazel, my colleague, said, where could George Mason help? I think spending some time in research of what's working and what isn't on some of these proofs of concept may not be an NIH study, but is this working in this particular population becomes a key way that you could be very helpful on the research agenda. Already mentioned medication-assisted therapy, starting that early. We're in the discussions of starting that on the inpatient and in our EDs. We haven't made that decision yet, but I think we have the follow-up care. So I believe that will happen in the next few months. Safeguarding against diversion. Program started with reviewing all of our internal focus on what are we doing with our care providers so they're not diverting drugs to themselves or to others as it relates to roll forward, and continuing to audit and strengthen that out as an issue. I'm using the AHA framework of what an institution should be doing, and I think where we could do some more work, and I leave that with some thoughts, care transitions. It's been mentioned that folks coming into the ED, treated with naloxone in the field, basically getting them to follow up is a real key challenge. We worked with the Fairfax County Opioid Task Force about a year ago, talked through what they were seeing. We hired a clinical technician who was calling everybody. We had the same results, unfortunately, that the police enforcement had, essentially zero interest in getting followed up. So what we're doing with phone calls and follow-up isn't working. That's another area that I would challenge Virginia Mason to really say, how do we get people continuously at the right time so when they're ready, their peers, their loved ones are reinforcing the fact that you need help to avoid what could be that next overdose and that next fatality in our community. That's an area where I think we can do a lot of work, and we continue to say, I'd give ourselves about a C. We have collaboration with a lot of community agencies, all of the EMS facilities in the multiple counties we serve, but we have to continue to do more work with that, and that would be, and then also engaging patients and families would be areas where I think we can and should do more. We have a lot of collaborations with Virginia Mason. We're working with the Department of Medicine, Professor Gerber, talking about a number of ways that we can use data to enrich our approaches. Behavioral health partnerships. We also are doing some work in genomic testing and what that can look like as a way to get the people the right drugs at the right doses. So with that, I want to thank everyone in this brief overview that we're doing a lot. What I'm concerned about and the challenge I give to my task force is this Brownian motion. Dr. Hazel and others led a lot of work, and we did a fabulous job with the Ebola crisis. We had the whole organization rallied around Ebola. Training, education, information, ongoing training. That was licked as it related, should somebody show up, what did we all do? Why hasn't this happened with opioid epidemic? This, to some degree, is minor tweaking, a little bit of a new initiative, business as usual, and we have to change that mentality. And I see heads nodding, which means some of you are also seeing that in the way we're approaching this. There's a chronic disease. It started over 2 decades. It didn't just happen in one area of the world, and we could do something about it, but we have to change the imperative to fix that. And I thought what was great was how strong is your C-suite involved in this initiative? Chief nurse and chief medical officer are very much involved in our organization. The rest of the C-suite have to get further involved. But if you look at other organizations who have done it well, I challenge you to go visit Christiana in Delaware as a real model. And when our team came back, they said the most amazing thing they found was this was a cultural transformation. The whole organization is talking about it. Every person is screened 3 or 4 times for not just do you smoke, are you overweight, and do you use alcohol. Have you or will you be using chronic substance abuse agents? Are you using the opioids? And really making sure when you screen positive, there's follow-up. That's a sign of a cultural transformation. We're early on that. We're going to continue to have to roll forward. So if we make this cultural If we really take this as a real crisis, I think we can do a lot more. So, broad overview of what we've been trying to accomplish with a number of partners of Northern Virginia, with the school, and with multiple other schools, but there's a lot more work to be done. So thank you.
Great, thank you. Okay, thank you, Dr. Flint. Our next speaker, Alexandra Duncan, the Pew Charitable Trust. Alexandra.
Good morning. So this is a little bit about what I'll cover today. Just to give a little bit of background on Pew for people who are not familiar with our organization. We're a nonprofit research and advocacy organization with a mission to help leaders identify evidence-based solutions to pressing public policy problems. Pew was founded in 1948 as the sole beneficiary of 7 trusts established by the Pew family. In 2002, we became a public charity. So what that means is we do more internal funding of our own research as opposed to grant making. Pew has 3 broad goals, which you can see on the slide. I'm from the Substance Use Prevention and Treatment Initiative. My team has been around for about 4 years or so. For the last 3 or so years, we've been focusing on prevention, prescription drug monitoring programs, patient review and restriction programs. We are now, within the last year or so, moving into the treatment space where we are providing technical assistance and federal advocacy to states to increase funding for substance use disorder treatment and to increase the cap for buprenorphine, which was some work that we did on the federal level. Our goal is to reduce the inappropriate use of prescription drugs and illicit opioids, as well as increase access to treatment, including medication-assisted treatment. My team consists of clinicians, policy analysts, and research staff like myself. Pew's technical assistance begins with a thorough analysis to identify the strengths and weaknesses and the gaps in a state's treatment system. We then work with that state to identify policy options that that state could push forward, and then assist the state with policy change. And that policy change could be regulatory, it could be legislative, it could be some other executive order by the governor. And in addition, Pew brings our full-time support to that state for technical assistance for 12 to 14 months at no cost to the state. So all of our services are provided for free. I talked about policy change in the last slide as it relates to our technical assistance model. Pew has tailored recommendations that I mentioned with, in that second round figure. That tailored technical assistance that provides those policy recommendations are focused on kind of 3 or 4 or 5, well actually 5 specific areas. Understanding the scope of the treatment system, engaging with stakeholders, building on evidence and emerging practices, and partnering with our national organizations. Pew has a lot of partners that we work with when we provide assistance to states, and identification of key influencers. We're currently wrapping up our technical assistance in Indiana and Wisconsin. We will be assisting 3 more states by March 2020. Our focus areas, which you can see on the screen, are for substance use disorder treatment workforce, ensuring a streamlined process for licensure and certification so that way treatment services can be provided. Treatment system transformation, providing systems of care for substance use disorder treatment services that integrate all types of services, coverage and reimbursement, supporting public and private payers for coverage policy and payment reforms to increase access to evidence-based treatment. Making sure that we are serving the most vulnerable populations, such as persons re-entering the community from criminal justice system, pregnant patients, people in rural communities and racial ethnic minorities, and identifying sustainable funding sources. So we often say with children, it takes a village. With this crisis, it takes a village, and nonprofits are part of that village, and we're here to assist. Some of the areas in which kind of nonprofits can plug in: advocacy, family support, also through policymaker advocacy, and depending on the size of that nonprofit may decide to do some lobbying. Research, The RAND Corporation is a partner of Pew. RAND is also a nonprofit organization and really assists Pew with some of our analytic support. For funders, foundations often provide support. I mentioned that Pew's work is more internally funded, but we do grant contracts to organizations to assist Pew with some of our technical assistance work. And lastly, with technical assistance, which I mentioned the work that we're doing in Indiana and Wisconsin. Opportunities for collaboration for everyone in the room to collaborate with nonprofits, to serve as subject matter experts, to provide data analytics support through research partnerships. Advocacy already talked about, but many of you in the room can serve as coalition builders. Many of you in the room can also serve to reduce stigma and informing the public discussion around this topic. Thank you.
Great, thank you. Thank you, Alexandra. Our next speaker, Phyllis Randall, Chair of the Board of Supervisors, Loudoun County. Phyllis.
Good morning. I do not have a presentation, so I do have a stopwatch, and so I won't talk over 7 minutes.
I can put this away.
You can. So a couple things. One, as well as being chair at large of the Loudoun County Board of Supervisors in Loudoun County, Virginia, I am also chair of Virginia's State Board of Corrections currently, and I am a substance abuse therapist and a HIDA prevention therapist. For this conversation, and probably most importantly, I'm also the daughter of an addict, of an alcoholic who was 28 years in recovery before he died, and I'm a sister of an active substance abuse and alcoholic who was probably, if I had to guess, in the pre-contemplation stage of change. So I kind of know what I'm talking about, to be quite honest. Normally when I do these talks, I actually have to talk about first the fact that we shouldn't just talk about the substance of opioids, that we should talk about heroin, we should talk about cocaine, we should talk about methamphetamine. Today, to my surprise and to my pleasure, we've talked about all these other substances. And that's important because we should be less concerned about the individual substances and more concerned about the brain disease that is addiction. And until we start talking about the brain disease that is addiction, we're going to just keep talking about the substance. It should also be said, and this is important, that this is the first time, the opioid addiction, that we start talking about what to do with the disease. I can tell you that a lot of people do not feel that this was the approach we had when the drug was crack cocaine. When the drug was crack cocaine, the approach we had was to jail people. And there are people who are sitting in jail who still are sitting there because the sentence for crack cocaine was longer than the sentence of powder cocaine. But luckily, we're moving into a new paradigm, and we're realizing that a drug is a drug is a drug, and that this is a disease, and it is not a moral failing. That's where we have to go if we're going to do something about this problem. I was asked to talk mostly as the chair of my county and what we're doing. So first I'm talking about what we're doing regionally. I sit on COG, the Council of Governments, and in the Council of Governments we have a subcommittee that is focused on substance dependence and opioids. When I first got there, it was just called the Opioid Task Force, and I, of course, said, we can't call it that. We've got to change that name. One of the things we're doing in that committee is we're doing PSAs. We've only met 3 times, and we decided to do PSAs. And the PSAs are really being focused toward family and their education and prevention PSAs, because oftentimes we do a lot of talking about the addicted person, but we forget that the addicted person should have a whole support system around them, and that support system has no idea what to do. And so the PSAs are focused on family members and also on younger people, so they're prevention PSAs. That's a good thing. Let's talk a little bit about my county and my county's response. First of all, I'm the chair of Loudoun County, which is the best county in the country, by far. In my county, we have been doing a few things. First and foremost, we have put in the budget positions to deal with these issues. I'm sorry, but if anyone thinks we can deal with this clinical condition without positions, you are sorely mistaken. I will say that we have been fairly underfunded in our behavioral health for years, but over the past 2 years, we have added either in family service or inmate SADS, which is our word for the CSB board, for the CSB department, 52 positions. That's a lot of positions, and that is required if we're going to do something with this issue. We are also doing trainings that are county-wide, including trainings where you wouldn't think of it. One of the groups we have reached out to is DAR, which is the Dallas Area Association of Realtors. So why are we talking to realtors about substance abuse? Well, because we have found that when people are drug seeking, they go into open houses and they're not looking to buy your house. They're looking to look in your medicine cabinet to see what you have in there. So we are talking to faith-based organizations. We are talking to DAR. We are talking to organizations like the Lions Club and the Rotary Club and people like that. We have something called the Revive program. The Revive program is focused on family members. They have to take a class, and at the end of taking a class, a family member will be given naloxone because they are living with somebody who is an addict. And so we want to arm family members. I will say, and this is important, naloxone is not treatment. Naloxone is not even detox. Naloxone is, let's keep them alive for a little bit longer until they can get to treatment. And a lot of times people get that confused. We're doing a lot of discussions and educations about what prevention is versus what detox is versus what treatment is. There are 3 different things. You often get people to say, well, my loved one went to treatment for 28 days, but they're still using because they didn't go to treatment. They went to a detox unit for 28 days, and so they actually haven't done treatment yet. We also have the Prevention Alliance of Loudoun, and in that alliance we have bags that we give people. They can come pick up to put their leftover medication in their bag and turn it back in. We want to make giving drugs back, substances back, as easy as it was to get them. So we're doing that in Loudoun County. And finally, we are trying very hard to get a drug court in Loudoun County. When done correctly, a drug court is a very effective mechanism. A drug court should be done post-arrest, but pre-incarceration. As somebody who was a substance abuse therapist in the jails, in the prison system for the past 15 years, I can tell you, once somebody goes to jail 2 or 3 times, they're not scared of jail anymore. So a drug court should be something that you want to do for them that is a preventative measure. You want people scared to go to jail. When you hear people say things like, I could do a bid, you've already lost them, right? And the truth is, and like this sounds terrible, once somebody's been thrift searched 2 or 3 times, they're cool, right? They can just do that again. So you want to do something in advance. So we're doing that in our county. There's also a lot of cross-training with our law enforcement, a lot of cross-collaboration. Our law enforcement, both our firefighters and our sheriff's departments, has naloxone on them. I called our sheriff before I left to just make sure I have the right number. This year alone, already, our sheriff's department has saved 15 lives with nasal Narcan, just this year alone. And so all of our sheriff's departments are equipped with Narcan. Our sheriffs are also doing something called the CIT program, which is a program that teaches a law enforcement officer, if you come up on somebody, what you may be dealing with, because somebody who is under the influence of drugs looks like there's a different look, and you want to try to de-escalate that person as fast as possible. I have 1 minute. Finally, I want to say that we're trying to do something with education. The fact is, we have got to lower the stigma of this disease. Being embarrassed about the disease will kill you. And so we're trying to do a lot of education about the fact that, again, this is not a moral failing. This is a brain disease with a psychosocial and biological component, and to teach people what that is. It helps to have the chair of the county be a substance abuse therapist who works in jails, because I've done a lot of education with my colleagues. I will do one more thing. I never leave a group without actually making an ask. My ask of you is to reach out to your elected officials. A lot of you are providers in this room. Meet with them, sit down with them, and try to explain what this issue is. It is easy to think that this is just nothing but people who are being weak, people who don't have any self-confidence, self-worth, self-discipline, and are more failing. Explain to them the disease, the brain disease of substance dependence, and it will move this conversation for all all substances that much further. Thank you so much for having me today.
All right. Thank you, Chairperson Randall. That was 7 minutes to the second. Wonderful. So our next speaker on public safety, Secretary of Public Safety and Homeland Security, Secretary Brian Moran.
Mark, thank you. And Phyllis, thank you for your passion on these issues. And recognizing that Sharon Bolivar has been here all morning, I am not going to weigh in on which is the best jurisdiction in Virginia. And having lived in Alexandria for 30 years and now in Chesterfield, we have some wonderful communities in the Commonwealth of Virginia. Great job. Well, we're last on the panel, so we're in the position of everything has been said, but not everyone has had a chance to say it. But I will try to introduce a couple of new topics, and some of the things that have been said obviously deserve some repetition from a law enforcement perspective. You know, Hughes Melton showed you a graph up there that was telling. It was obviously here to present with respect to opioid death increases and drug deaths up over 1,500, 1,227 attributable to opioids. But the other graphs were also pretty important to me in that gun deaths are over 1,000, traffic deaths are over 900. So, you know, that's 3 people a day in Virginia dying by drug deaths and then traffic deaths. And so I think the increase in use of opioids also contributes to the increase in those deaths. Gun deaths, 60% are attributable to suicide. And traffic deaths, of course, there's some distracted driving, which we're trying to do something about with the legislature, but then also driving under the influence of drugs is a major contributor as well. So, you know, this is indeed you can't look at one issue without looking at the entirety with all the associated risks and threats facing us. So we approach this not just from a law enforcement perspective. When we took office under Governor McAuliffe, Bill Hazel and I, one of the first trips I took was to Clark County, met with sheriffs from that area, Northwest region, and Sheriff Roper said we cannot arrest our way out of this, and that has been repeated ever since, and it is a truism. Law enforcement has to work hand in hand with our medical community, and that's why Bill Hazel and I had worked so closely over the last 4 years, and I look forward to working with Secretary Kerry as well on these issues. From a law enforcement perspective, our law enforcement, Sheriff Kincaid, her colleagues in Virginia State Police, local police departments, DEA, FBI, doing a phenomenal job. The seizures of drugs since 2010 have increased substantially. Methamphetamines, 88% increase. Cocaine seizures up 100%. Heroin up over 200%. But these are cockroaches. I mean, they're just going to keep coming back. So we have to address not just the supply, but the demand. And that's why a conference of this nature is vitally important, and all the things that Phyllis listed and all the previous speakers have listed. The drug take-back program, with our partnership with DEA, has been a wonderful service. Everyone here, and you know, when we're talking about an ask, you all need to be involved in that. Post it on your social media networks. In Virginia, just in October of 2017, we collect over 26,000 pounds of opioids. A variety of things, actually. It's amazing what people bring to these drug take-backs, but a lot of it is the stuff you actually want to take out of people's medicine cabinets. We provided our daughters hydrocodone. She had, and I always have to be a little careful about criticizing the medical community since I worked so closely with Bill, and now I work for a doctor, Dr. Northam. But she had her wisdom tooth extracted and received a 7-day prescription. You know, it's a bottle like this, and it was cherry flavored. And you all remember Joe Camel. You know, we got rid of Joe Camel because you didn't want to attract cigarettes to kids. I mean, that thing should have had a skull and crossbones on it. 7 days. I'm old school, you know. I don't have a PowerPoint presentation. I got notes. I'm over 50, so I don't use the iPad that Phyllis used. But when and more importantly, my parents were old school, because when I had my wisdom teeth extracted, I got a couple of aspirin and suck it up. Now, I'm not suggesting that. I'm not suggesting that. But is there not some middle ground between 7 days and sucking it up? I mean, I can still remember it, so I know it was painful. But I got over it. So she received 7 days. The first day she was taking it, and we could see, her personality totally changed. She started reciting all of the Office. She loves the television show Office, and she started reciting all of the characters, but I digress. And so we took it away after a day, and she wanted more. I said, no, you're not going to get any more. Unfortunately, my wife was totally a partner with me on this. No, you're not going to get any more. So we contributed that to the drug take-back program. And so we have a terrific relationship with our federal partners. And I want to give a shout-out to Congresswoman Comstock. She helped get more money for HIDA because the high-intensity drug trafficking areas provide tremendous resources and create that necessary integration of local law enforcement with our federal partners. And frankly, we have Clark County, Shenandoah, Winchester, and hats off to that entire region, because they have really taken a leadership role. And let this introduce the one other subject, well, drug courts. Virginia, frankly, is not doing a good job around drug courts. Bill Hazel and I were out in Southwest Virginia with partners from Tennessee, Kentucky, West Virginia, North Carolina. West Virginia has a drug court in every jurisdiction. West Virginia, I'm sorry, anybody here from West Virginia? Oh, I'm sorry. Really? West Virginia is doing better than us when it comes to drug courts? We have 49, but we have 134 jurisdictions in Virginia, and 49, sometimes there's a juvenile court, there's a drug court, there's a drunk driving court. Fairfax is working on a mental health court. We have to do better. And, the cultural change here, folks, is a drug court is soft on crime. That's what it is. It's fact. That's what we run up against when we try to get state resources to help a locale. Localities don't have the resources to create their own drug courts, because drug court is not just about, well, you know what, I'm not going to throw you in jail today. I'm going to let you have an alternative program and show us you can stay clean, get a job, take care of your family. Well, that isn't that. There's a lot more than that. There has to be wraparound services. There has to be monitoring. There has to be treatment. There has to be counseling associated with that, so that resources are necessary. So Virginia can do a much better job with respect to drug courts. Now, I will tell you, the legislature just passed legislation, became effective in March of this year, marijuana oils for alternatives to treatment rather than using opioids. That's been a subject this morning. And that's pretty big for Virginia. Going medical marijuana. It wasn't long ago that it was totally illegal, and now we've gone ahead and we're going to provide 5 distribution centers that are providing oils. So that's a pretty big step for Virginia. The immunity statutes in Virginia, so you'll hear a lot about the Narcan. That's not treatment. When me and the governor were at the Chesterfield jail, and we asked folks, who started with prescriptions and all, but about 2 or 3 hands went up. And then we also asked them, well, how many of y'all have used Narcan or been, revived by Narcan? And half of the hands went up, and now they're in jail. So, that is not a substitute for treatment. Now, the life-saving device, no question, Virginia Beach has similar statistics as Loud, and, we're saving about a life a week from the administration of Narcan. We're giving it to our probation officers. Department of Forensic Science needs it because a lot of this fentanyl comes in to the Department of Forensic Science to test, and it is lethal, and law enforcement needs it because not to save others, well, in addition to saving others, but save themselves if they come in contact with carfentanil and fentanyl, because it is so lethal. So we are indeed, and Virginia State Police also is trying a pilot program possessing Narcan as well. And if you haven't taken Revive, the governor have taken the Revive training. It's very, very simple, so you should do that. But the immunity statute, so say somebody makes the phone call, my friend has passed out, they're in the middle of an overdose, they're going to die, they call 911, police come. Some states have adopted immunity statutes that say as long as you have called 911, you shall not be arrested. Good Samaritan statutes. In Virginia, we've gone half a step. We've said it can be an affirmative defense, meaning you'd be arrested, but at trial or during the prosecution, you would have to show that you were doing it while someone, you made the phone call to save a life, and so the case would be dismissed if you were successful in showing that affirmative defense. So let me conclude with this one. Good news. I mean, there's a lot going on in the state. We're trying to take some very innovative approaches. We have worked with our National Governors Association. This is happening in every state. It's happening in every region of every state. So it does require everyone to be at the table, engaged in eradicating this crisis and epidemic of overdoses. But what we are doing with our DOC population, Department of Corrections population, we are trying a pilot program for some of our inmates who are amenable to treatment. We're going to provide some intensive drug treatment services while they are incarcerated. We're also going to administer the drug Vivitrol. It's the new magic drug. I'm a little reluctant. We're treating one drug with another drug, but all the health experts say Vivitrol works. So I have a law degree, not a medical degree. So we're going to provide Vivitrol. It lasts for 30 days. They're going to be released. And what's so vitally important is that we will have addiction navigators to monitor the progress of that inmate. We have three jurisdictions that have stepped up, Norfolk, Richmond City, Tazewell, so we have an urban and rural area of the Commonwealth, and our community services boards have stepped up, vitally important. Governor Northam mentioned $30 million for same-day service, critically important component of this response. And so we're going to try that, and Alchemies, the company that produces Vivitrol, is providing the first dose free, and then we're working out additional treatment once they are released. That'll treat about 25 to 35 inmates, and there's a cost associated with it. So, obviously there's a need for resources. If it works, if we're able to keep those folks away from drugs, back into the community, and self-sufficient, it will work, and it'll be worth it, and we'll request additional resources. So I guess the bottom line is a very collaborative effort on the state, from our health and law enforcement working very collaboratively. You all in your communities, that I know many of the communities are doing just that. So, and all hands on deck. This is 1,227 opioid lives, over 1,500 drugs. Over 1,500 lives have been taken by drugs overall, and so it is indeed a crisis, and everybody needs to respond and be a part of its solution. Thank you.
Thank you, Secretary Moran. I believe we have about 10 minutes for questions and answers session, so feel free to come forward and ask your questions.
Good morning.
Please.
Well, Phyllis, you're my hero today, so I just want to applaud you again for giving the family voice. When Dr. Hazel asked about people in recovery, I raised my hand because we are a family in recovery. I am a daughter of a alcoholic, and I'm a mother of a 24-year-old in recovery. 2.5 years, no evidence of disease. And the reason we attribute that to treatment and education and our family learning how to provide an environment that supported recovery. So what I heard a lot today about is prevention and treatment, but not a lot about strategies for creating an environment that supports recovery, and then also educating families how to create an environment that supports recovery. So maybe you can elaborate on the strategies that you're using to educate families to influence treatment. I also became certified as an interventionist after this because I needed more family support, and I learned ways to connect with families. So I work with families one-on-one, but how can we do that in a bigger way, do you think?
Well, first of all, thank you. You know, it's interesting because I did talk to my father before he died about his disease, and he used to always say, if you can help anyone by saying that I had the disease of alcoholism, say it, and said the same thing to my sister. I think the first thing we do is actually just say it, because it takes the stigma away. It is a disease, right? So that's the first thing. I think what we didn't talk about today is what both the faith community and self-help communities can do, and how they are of help. When my father was active in his use, my mother used to take us to Al-Anon meetings all the time. And my mother used to always tell us, you didn't cause your father's problem and you can't solve your father's problem. And then when he got in recovery, we all went together as a family. So I also believe that it's important for every family member to know how to be supportive without being enabling, and to know that their entire life can't be about their person who is in addiction. They have a right to have a life outside of just dealing with their person's addiction. And that there is both support groups out there, through your CSBs, through your inmate SADs, again, through the self-help community, through your church, and that type of thing, to put support around you. I used to say to my inmates all the time, you cannot create for yourself a support system in your emergency. It's too late. So put the support system together, because the emergency is going to come. So I think if we normalize this like we've normalized every other disease, some of those supports are already in place. I hope that helped.
Sorry. Using the support system to also teach families that they can influence treatment without enabling a disease.
Absolutely.
You know, there's a fine line between turning your back
being supportive without being enabling.
Yeah,
absolutely.
Turning your back and saying there's nothing you can do, to there is a way to influence treatment. Yeah.
Okay, we'll
Thank
go
you.
to the next question. I'm just going to go in order from one mic to the next and then back again, and let's make the questions relatively quick with the time limit we have. Thank you.
Sure. Hi, my name is Laura Freeman. I'm a first-year master's student in the public health program, and I'm studying out health communication. I had the opportunity to intern with the Entertainment Industries Council, and that was when I first kind of started learning about the opioid crisis. But one thing that I'm learning is how we're framing the message, and it's really important that we can tell people that they can post on their social media about this issue, so everyone is learning more. But if it's not framed correctly, if they're not knowing what to even post, it's that's kind of an issue. So I was just wondering, how can communicators be brought to the table to make sure that they can inform just best practices on, okay, this is how you can use your social media correctly to get this information out. So how is that being done, or what are different opportunities that can be presented for even students like me to come and present ideas, I guess?
Thank you. Anybody?
Well, I'll address this from a little bit different perspective. We also see social media as a potential source of information about the emerging epidemic. So we're intrigued by some new studies that are being launched to use Twitter platform and others as a source of information about what substances people are using, and perhaps even detecting who themselves has a problem versus who's kind of talking about it in a different way. So there may be some creative ways to use social media in an unexpected manner. But I would look to some others to help us figure out how we can maximize our impact on the public by creative use of the platforms for communication.
I sound like a broken record, but I would say again, to talk about like a disease. I have a couple of friends of mine who are going through chemo, and they will post on their social media, today's my last day of chemo, or I've been cancer-free for 2 years. And then they get all kind of people that say, good job, how can I help you? Should I bring you dinner tonight? What can I do for you? I can keep your kids. If somebody says, I'm going to my first recovery meeting, or I've been in recovery for, then they have no comments on their Facebook post, right? And so I think it's just about those of us who are in the provider field helping people learn how to talk about this, and that is a brain disease, and that people can talk about that and say, I've been in recovery now I'm going to pick up my 60-day chip today, and put it right out there. So in some ways, we may be overthinking it, Talk about it like you talk about every other disease.
Okay, next question, please.
Hi, my name is Sarah McDade, and this is for the higher ups. I really relate to what Phyllis Randall is saying, but this is more for ANOVA or Pew and other people in higher places. The family has been left out in terms of being a resource to helping that sick person get into treatment. I moderate a number of family support groups, parent support groups. We educate the members who come to our meetings. We learn how we can change our own behaviors and move that needle further to treatment process. So I create resource lists as my passion. I have about 15 resource lists. The most popular one is the 2-page parent support group for this region. And you see tremendous change in the family members from the first day they walk in until a year later, and you see what's happening to their loved ones who've been sick who are now getting treatment. So if anyone wants my resources, I'm here.
Great, thank you. Thank you for that offer. Okay, please. Yes.
I'm Jenny Atwood Lovett, and I lost my little brother Christopher to a heroin overdose in 2013. And in his memory, my family and I started the Chris Atwood Foundation. So what we do is provide overdose reversal trainings and free Narcan in Northern Virginia. We also do political advocacy, legislative advocacy, as well as recovery supports. First of all, I want to just commend whoever it was that mentioned, multiple people I think have mentioned the concept of meeting people where they're at. I think that needs to be said over and over and over again, because what we've experienced is, trying to hold Revive trainings and get people to come to us has a limited amount of success. We usually get people who are in the healthcare industry and that kind of thing. But meeting people where they're at, in terms of going to homeless shelters and going to recovery meetings and parent support group meetings and really integrating out into the community is where we reach the people who really, really need this. Because until the stigma is eradicated, people aren't going to come out of the shadows. We have to go meet them there. My question is for Dr. Flint, is it, of Inova? There is some really encouraging research coming out of Yale regarding what was mentioned earlier, starting buprenorphine treatment in the emergency department after an overdose, as well as sending people home with take-home naloxone. I'm not aware of that happening at Nova, and so I'm wondering, is that something that is coming down the pipeline, and if so, when?
Yeah, I think I did mention quickly that we have a new chair of psychiatry right now. He's been here for about 3 months, and with that, it's on his agenda to really start getting that program going. So I think you'll probably see it as soon as we've been able to socialize it a little bit more, but it's certainly something that there's enthusiasm from the medical community to move forward with that, and it's just with 5 hospitals, it's going to take a little bit of time.
I want to clarify one point you made. In the Yale study, most of those patients were not overdose, because that emergency room, like many others, has the same experience that was described, that patients who've overdosed and been resuscitated aren't always that interested in treatment on the spot. That's a major gap in our system, and we don't always know what to do with them. We've launched a series of research studies to try to address that. So we have colleagues in Illinois and Indiana, among others, that are trying to develop novel models, whether that's peer outreach a day or 2 later, wraparound services, or others. The Yale study, about 10% of the participants were overdosed, but the others were people that came to the ER seeking treatment, had an injury, had a laceration, had a cold, other things that brought them to the ER, but happened to have an opioid use disorder.
Great.
Thank you. And to follow up real quickly on that, about peer support, I'm also told that Inova, I think Alexandria, is starting a pilot program to bring peer support specialists into the emergency department. Is that moving forward?
It's moving forward. It's actually going to be piloted at Mount Vernon, not Alexandria. But I think that started with the collaboration we had with the Opioid Task Force from Fairfax County, where we all threw our hands up and said, wouldn't it be interesting if perhaps we had individuals who have dealt with either recovery themselves or their family could come in and meet the person in the ED and just introduce themselves, say, this is my journey, here's what's going on, and we would love to follow up, because it isn't working with the police, it isn't working with healthcare professionals, and so we're going to pilot that in Alexandria. At Mount Vernon.
Thank you.
Great, thank you very much. I think what we'll do is have the next 2 questioners ask their questions one after another, and then open it to the panel, given our time constraints. So, yes, please.
My name's Chris Rezengata. I work here at Mason Student Health Services, but I've also had the privilege of working at a couple of different medication-assisted treatment centers in the area. My question for the panel, I've been able to work with people in medication maintenance therapy for long periods who still struggle with the shame of, I need this substance in order to maintain my recovery. And they don't see it as a real or valid form of recovery. For some of them, even when they go to peer recovery groups outside of the agency, they find they cannot share that they're in medication-assisted treatment. So I'm curious to know what we can do as a community to really promote medication-assisted treatment as a valid form for recovery.
Great, thank you. And your question?
So my name is Nick Yakub, and I'm a certified peer recovery specialist with the Fairfax Falls Church Community Services Board, and I'm also a person in long-term recovery. The panel had brought up stigma and using social media, and this is more of a question to the audience real quick. How many people in here are using social media? Currently you have a social media account, show of hands real quick. Okay, so how many of you have tagged yourself as being at this opioid symposium? Okay, we should get more hands up. I'm just throwing that out there. Thank you.
Great, thank you. Okay, any last words from the panel? And then Deb Crawford will be coming up, our Vice President for Research, to talk about leveraging Mason's assets.
Well, we'll start this way and back. How's that? Good.
Excuse me?
We'll start down this end and move back.
Okay, that's fine. Thank you.
On the social media front, I had mentioned that because April 28th is a drug take back, and everybody should be advertising that. And then 26,000 pounds is a lot of medicine to be taken out of the medicine cabinets, and we know that particularly with around teenagers, they know who is receiving these. I have a teenage daughter and a teenage son. They know who has access to these, and they will go to a medicine cabinet. So that is something simple. Talk about takeaways. I mean, everyone in this room can do something, advertise that, and then do it. You bring it down to the drug take back, take a nice photo, and put it on Facebook. Maybe Instagram, depending on your age. With respect to MAT, as I mentioned, the pilot program we are using is medically assisted treatment with Vivitrol and others. And, several of the jails, the HARP program is not MAT. It's using more peer-to-peer support, but a successful program in Henrico is using medically assisted treatment. And so it's one of those things, everyone is trying to address this issue. I think it's important for a conference of this kind to network and share information so we learn best practices, what is working, what is not working, and so that we can apply those effective measures. But as Hazel, I'll mimic Hazel, medically assisted treatment is just that. There has to be it's assisted. There has MAT, but you have to have the treatment and counseling. One without the other won't work. So those are my final thoughts.
Okay.
Oh.
My final thoughts would be almost where I started, and that is that 25 years ago we were talking about cocaine in freebase form. 15 years ago we were talking about PCP. 5 years ago methamphetamine. Today we're talking about opioids, and 5 to 7 years from now we're going to be talking about something else. Let's stop doing that. Let's stop talking about the substance and talk about the brain disease that is addiction. If we talk about the substance, we win small battles, but we lose the larger war. To answer your question, it's interesting because as a therapist, when I first came into the profession, not that long ago, I actually was not somebody who cottoned to the ideal of long-term medical assistant treatment. That changed over time when I realized what these substances have done to the brains. And I describe it like diabetes. You do education about diabetes. You put them on a good course. You get them medical care. You talk about diet. You talk about exercise. But you still give them their insulin.
Right. Okay. Others?
Yeah, just to address your question, self-stigma is a problem. And Pew just wrapped up some qualitative work in Indiana and Wisconsin where it came out very strongly among people in the recovery community and people who were actively misusing opioids about the stigma around using medication-assisted treatment. All of us have an opportunity to address stigma by talking about the goals of treatment, that medication-assisted treatment works, and that what's going on here is not a moral failing. So that just addresses your question. And for my final comments, I would say, people, please come talk to Pew. We are here to help. We are a service provider and provide states technical assistance. We've done technical assistance light touch for specific questions people may have. And so we are here to serve. Thank you.
Great, thank you. Doctor?
Yeah, I would just close with one comment. I know Blue Cross Care First was here earlier today. We have a ton of data, particularly regarding our providers, that's in silos. And I would challenge us, the Virginia Prescription Monitoring Program is exceptional, but the report goes to the individual doctor, and it isn't shared even in the aggregate as it relates to, in my role, what's going on with my NOAA physicians, how can I use that as an educational tool? But if we unleash the data, I would tell you, doctors respond very well to report cards. When you put C-section rates up in the birthing suite, guess what happens to the person with the highest rate? It drops immediately. And I'd say the same thing with the opioid work we did on Dilaudid in the ED. When that was published, all of a sudden the outlier wanted to be closer or beat the mean. So I would ask that you start thinking about how you can share in the aggregate. I'm not trying to get involved with any individual, but clusters of like providers and pushing their patterns of utilization is going to have a big difference on the provider community.
Great. Doctor, last comment.
Well, I appreciate the opportunity to emphasize how science can both inform many of the discussions we've already heard, but I want to turn back to the question we heard about how stigma is this very serious issue, and either self-stigma or professional stigma around people who are on medications for an opioid use disorder. I think we address it by talking about it here, by people being open about it, and it is a process change. That it won't happen overnight, just like other times people being more open about their cancer treatment or their heart disease treatment. This didn't happen, that was not routinely talked about at all a number of years ago. So I would use that example as to give us some hope. I would also say that NIH is open to research studies on this type of question. We funded John Kelly at Harvard University to study how language affects the stigma that our patients face. It turns out that the term abuse, when you use that to describe a patient, this person is a drug abuser. When you use that label, professionals have a slightly more stigmatizing attitude toward that patient. So if we simply, and all they changed in these descriptions was person with a drug use disorder or person who was a drug abuser. Everything else was the same, and yet the attitudes were different. I think that reminds us that small places can make a difference, and we're open to support research studies from Mason and other universities and other researchers around here to study these kind of questions. Thank you.
Great, thank you. That's a nice segue to our next session, which will be leveraging George Mason's assets. Dr. Deborah Crawford, the Vice President for Research at George Mason University. But first, let's thank our panel for great discussion.
Take my notes back. You can take yours. All right. I would have been confused. Good morning, everyone. As Mark indicated, I'm Deb Crawford, and I'm Mason's Vice President for Research. My boss is in the room here. It's Bill Hazel. Like many of you fans of Bill, I am also a fan of Bill. We've worked together for a reasonably short time, but the number of things that have been accomplished in that short time are truly amazing. So I just wanted to share with you sort of my impressions of this gathering and the types of things I think that we'll be able to do together moving forward. It's truly inspirational to see such a robust response to this symposium with so many of our partners in the community coming together to sort of share with Mason faculty and students the types of challenges that you face and inspire the types of research and scholarship that we can do in service to you and to the citizens of Virginia. So one of the hallmarks of Mason research and scholarship is research of consequence. Thinking about generating, I think it was Alex who used this term, generating evidence-based solution to public policy challenges.
And I can't think of any better challenge than sort of better understanding and addressing the challenges of substance abuse and addiction. So for Mason, this is an all hands on deck kind of problem. You already met two of our deans. The deans called Mark the moderators. And we also have a number of our other deans here in the audience, as well as faculty from all of our colleges and schools. So when we address a public policy challenge like this, we do not see our disciplinary silos or boundaries. We come together and rally around providing the solutions to the problems. And I think you'll see this in the video that we're going to show. So to make best use of time possible here this morning, since we're running over, we've prepared a very short video just to give you a sampling of the types of research projects and programs that are currently underway at Mason and that you can leverage as we work together to address the opioid epidemic and substance abuse challenges more broadly. So with that, I'll ask you to run the video. Thank you.
Opioids and the conditions that lead to misuse and addiction. Misuse and addiction and the deaths and damage they cause are major problems for the United States, Virginia, and the conditions that lead to misuse and addiction, and having opioids and the conditions that lead to misuse and addiction and the deaths and damage they cause are major problems for the United States, Virginia, and Northern Virginia. As Secretary of Health and Human Resources for the Commonwealth of Virginia for the past 8 years, I learned that problems like these are solved in communities like ours by collaborating and coordinating and having hard conversations, addressing underlying conditions and attitudes. George Mason University is uniquely positioned to help address this crisis as an innovative, major research university with the mission, talent, and expertise to solve big, complex problems through research, education, practice, and convening. George Mason has committed to help. Listen as some of our award-winning faculty discuss what Mason can do to facilitate and lead efforts to eradicate the opioid epidemic in Northern Virginia.
Can one screen change a life? Yes, it can. Mason has developed significant expertise in identifying people at risk for substance use disorders through universal screening processes and early interventions to change trajectories for many. Prevention measures thrive within the integrated care models Mason has implemented in a variety of clinical settings. Training on evidence-based practices that work and valuable support to sustain these critical prevention initiatives is available through Mason's multidisciplinary faculty. Community partnerships are important to Mason to inform an innovative yet practical approach to prevention. We all share the common goal of preventing substance use disorders and maximizing population health and well-being.
The costs of the opioid crisis are varied, and teams of Mason researchers with health policy, economics, nursing, social work, psychology, public health, and data analytics expertise can effectively map and quantify them, both locally and nationally. The greatest cost, of course, is human, in the thousands of lives lost or ruined each year by the epidemic. Economically, the largest costs are from lost wages and taxes unpaid from missed work, emergency health care and longer-term treatment costs, criminal justice spending, family and child assistance, and finally, extra educational system spending. The specifics will vary by locale. An accurate estimation will require data and multidisciplinary dots to be connected. Accounting for these costs is essential for policymakers to see the wisdom of investing in recovery and harm reduction alternatives for individuals and communities alike. Mason scholars are experts in these areas and are well positioned to join and help lead community efforts to eradicate this scourge from our society.
Recovering from addiction is incredibly hard. The stigma, whether related to legal opioids and alcohol or illegal drugs, makes it even harder. Entire families are affected, and if you can't get housing, a job, or support your children, relapse is almost a given. Data shows that even medical professionals contribute to the stigma of substance use. Here at Mason, faculty, staff, and students work to fight stigma daily, given our mission of inclusion and connection with our community. Our hope is that by working with you, we can make recovery and transition easier and successful. At Mason, we have professors across the university already working with the underserved and minority populations, helping to decrease stigma in medical settings, and even working with police in rural Appalachian Kentucky to help change the addiction cycle. We have developed police and community partnerships and bring evidence-based practices into the real world. We help teens disclose substance abuse to their parents. We help adults reintegrate into society. At Mason, we strive to foster a culture of acceptance and growth every day.
Today's criminal justice is about more than enforcement. Integrated processes focused on substance abuse often include elements of harm reduction, prevention, treatment, and measured interdiction. Mason's award-winning criminology, forensics, and policy and security expertise is anchored in basic research and evidence-based practices. From working side by side with local officials and community groups to testifying on national policies at congressional hearings, Mason brings practical solutions to our everyday challenges. Our research teams span our colleges and schools and include groups such as the Center for Evidence-Based Crime Policy, the DHS Center for Excellence on Criminal Investigations and Network Analyses, the Center for Advancing Correctional Excellence, the Terrorism, Transnational Crime, and Corruption Center, and the Center for Justice Leadership and Management. The work in these programs are just a few examples of how Mason scholars are addressing the opioid epidemic.
What interventions work, how do they work, and for whom do they work? Mason faculty are working hard to find the answers to these questions. We develop cutting-edge interventions, test them in randomized clinical trials, and share them with our broader community. Our data analytic experts carefully evaluate our interventions using behavioral, physiological, neuroendocrine, and neuroimaging assessment tools. Our state-of-the-art fMRI scanner allows us to study the brain changes associated with our interventions, from internet-based to in-person behavioral health treatments. We develop treatments for a range of settings and clinical populations, from hospitalized adolescents to incarcerated adults. We train the workforce to deliver these interventions using scientifically sound training and supervision models. We work closely with organizations who wish to implement and sustain the use of these interventions in their community settings. When in direct need of help, Mason is also there. We offer evidence-based treatment to the community through exemplary graduate training clinics, including the GMU Center for Psychological Services, the Mason and Partners Clinics, and the new Peterson Health Sciences Center clinics.
An important part of data and technology is to enhance treatment. Mason's technology-assisted care has helped providers offer more effective care. Mason's artificial intelligence technology was used to screen for prescription abuse with surprising success. Our AI methods of screening are more accurate than physicians. Mason's data integration techniques were used to coordinate care across medical records. These techniques are helpful to integrate addiction counseling with primary care. Mason's advances in the use of wearables and phones were helpful in extending care to the community and monitoring relapses. Mason's methods of online counseling were used to support primary care with remote, daily addiction counseling. Patients who received online care were less likely to have positive urine tests. In short, Mason's technology-assisted care provides a virtual, wraparound service for effective, prevention, and treatment.
Mason's commitment to working with and on behalf of our many communities remains strong, and we are convinced that eradication of this epidemic is possible with the development and implementation of novel interventions addressing all aspects of public health prevention. From the perspective of Mason faculty, the time to act is now, using efficacious tools suitable for population health. We believe that evidence-based practices supporting the design of novel interventions to interrupt the life cycle of this epidemic are possible as we work to ensure the health and well-being of the many populations we serve. The time is now.
So as you can see, there's a lot going on here at Mason. I thought that this might be an opportune moment to actually acknowledge the steering committee who actually organized this symposium. If you wouldn't mind standing up, some of the stars of our video, but others who were in the supporting cast, if you could stand up and be acknowledged, please. And a special thank you to Dean Buck-Lewis, who ended the video here, for her leadership, and to, of course, Dr. Hazel. It was Dean Lewis and Dr. Hazel who really did put the lion's share of the leadership activity into this symposium, and we're truly grateful to them. So with that, Bill, are you coming up to do the next session? Thank you very much.
Okay, thank you, Deb. And if you can see from the film, you know why my future is in radio and not TV. All right, we had promised you some public comment time, but we're really short on time, and Dr. Lewis is going to wrap up. But anybody want to make any suggestions or comments? You know, we're thinking here at Mason about how we follow through. It's not about having a meeting. You know, it's about what we do after the meeting and how we think about things as a region. You know, the one thing we talk about, we hear the great things that have been done in Loudoun or maybe in Fairfax or Alexandria Principal, but people move during the course of a day. And where our people come in contact with the system changes things. So it's important to think about how we do share information. And when we look at limited resources for actually public announcements, public service announcements for prevention, stigma reduction, things like that, we need to think how we do it more globally. Playing whack-a-mole, it may be great if Inova's got a program in the emergency room, so what does a smart person who's addicted do? They go to a different emergency room. How do we come together to think about things like that is really what we need to be getting to if we're going to make this work, I think. The group here, I did want to mention, we have Virginia State Police here. I know Quentin's here. I don't know who else. Where are you, Quentin? Back here, Quentin Kelly, who's Virginia State Police. Just to get some examples from the state, Behavioral Health and Developmental Services. Melly Randall, where are you, Melly? Melly is an national award-winning public or behavioral health worker in prevention work. She's been recognized for the work she's done for many years, actually laboring in the wilderness, telling us this was coming when we weren't listening. So we've got people, we have some industry folks. I know IBM is represented here. I think there's a Microsoft representative, our insurance colleagues. We've got lots of people from different areas here to compare notes. So anybody like to make any comments now? It is now time to tell me what I meant to say today. Sheriff Kincaid's going to jump up and do that.
First of all, thank you to everybody who has participated on the panel and for those folks that have shown up. And I believe it was mentioned earlier about something that we're not hearing as much of, and that's the recovery community. It's something that I think, based on, again, what's been going on in Chesterfield with the authenticity of a program where we're focused on having those folks that are in recovery continue to help us out with recovery. And I think that obviously connecting everybody, the experts with the recovery community is paramount, it's critical in order to do something and to help in this eradication process. So certainly if there's opportunities for Mason to come and work with us, because we're going to be implementing an addiction recovery program, and again, it's not just for heroin, addiction is addiction is addiction. So again, we're going to be strongly focused on a program that I think is going to certainly make a difference in many, many lives.
Thank you. These ladies are listening right here, but you got Nick Jacob all upset right there by saying we're not hearing from the recovery community. Around the state we have, and I can tell you one thing didn't come up today that we did at the state level is we implemented the Medicaid program and Addiction Recovery Treatment Services waiver. It only works for people who are covered by Medicaid, which means 90% of the people who need it don't get it right now. That may change with the General Assembly, we hope. If the General Assembly does expand Medicaid, we'd expect another $200 million a year for mental health services and $100 million a year for addiction treatment services, and it's going to take some resources. So I'd say that, but what I wanted to point out is that in the treatment or in the waiver, we actually pay for peer counseling. And there is a certificate that you can get. We've grandfathered a lot of people, and I say we, Melly will correct me if I'm wrong, but this took work between Medicaid, the Department of Behavioral Health and Developmental Services, and health professions to come up with the plan. And we actually will have a registry of peers who are qualified to be paid for providing services. So what we know is that the peer interaction is important. We know that. You heard Nida say that right here just a minute ago. We know that's important, not just to the people they're helping, but to help folks stay in recovery. So some of the jails that have done that have had great success. So I think it's important. So thank you.
Absolutely. Just one more thing, because having peers, and I didn't mean to say we haven't heard enough from, our peer folks in the audience, but again, plans on how can we improve the whole recovery process and make it something that people are focused on recovery. We can do MAT, we can do a whole lot of other things, but at the end of the day, and to eliminate the stigma, this is where the community comes together. And again, for somebody to go to a meeting after they get released from jail, it's always great to have a peer that is able to help, get them, reintegrate them back into the community. So thank you for that.
Isn't it great to see a lady in uniform say the same thing that our therapist over here said earlier? It is terrific, so thank you. Anybody else? Last minute advice. This afternoon in our work groups, we'll be breaking out, and we do have people who are in recovery in these work groups or families of, which I think will help inform us. The stigma conversation was particularly interesting. The young lady asked a question about framing. There is a group that actually has an office near here called Frameworks, and that actually has done some testing of messages in different places around what works for reaching the community about encouraging recovery. The one, I can remember some of their examples, but these are things that if we decided to do together, it's a lot more cost effective than if we try to do it all separately. But we can think about the messages and test them and actually come up with the things that can be said, I believe. So I'm optimistic that we can add some solutions. So, Jermaine, would you like to have the last word of the morning? I'd like to introduce you to the Dean of the College of Health and Human Services, Dr. Jermaine Lewis. Jermaine, close us out.
Good morning, and soon to be good afternoon. I really would like to just take a moment to reiterate several of the previous presenters to thank the speakers and panel members today for what I think were really, truly great talks. So thank you very much. And also to all of you who are participating today. I'd also like to give a short call out and acknowledgement to our provost, David Wu, who in November charged the faculty across the various colleges and schools at Mason to come together to work to respond to the opioid epidemic and to come up with solutions for the many communities we serve. So thank you, David, for bringing us together. So you can imagine between November and many faculty, myself being new, only having joined on October 1st, coming together from very different lenses and perspectives and training programs. It took a bit of time to get to know each other, But in a very short period of time, and then joined by the leadership of Bill Hazel, we were able to put together this workshop. And we were absolutely overwhelmed and moved by the response of our many partners and our communities to engage in this conversation today. So thank you very much. We remain committed to believing that this epidemic can be eradicated and that we can work to prevent the occurrence of others. So we've had a chance to hear about the epidemic from many lenses and from many views, and I think it's important to remind ourselves that we've also heard about hope. The promise of prevention, the promise of recovery, all underscored by the commitment that so many people have to working to eradicate this epidemic. We strongly believe at Mason that evidence-based practices and new discoveries using sound methods and tools are what is needed to help intervene in our communities. Before everybody scoots, I just want to give you a sense of what to expect from this symposium today. This is just not a one-time conversation, but it's actually the beginning of a continued, what we hope will be conversation, coming together, partnering, and responding to this epidemic. We will be preparing a report that will capture the key content that was discussed here today, both in the morning and also the afternoon sessions, and this will be publicly available to all on the website. I don't have an exact date yet, but knowing the provost, it won't take that long. It will be available, and we'll make sure that you all have access to that, and please do share it with others. We also are planning to prepare grant applications and contract proposals, not only just with Mason faculty and partners, but community groups, and we're open to a whole host of ideas. So we'll be continuing to align our research interest and focus on which aspect of the epidemic that individual groups and research teams might wish to pursue. And most importantly, we plan to monitor the impact, the collective wisdom and efforts of the many groups that will be working to eradicate this epidemic. And I was very pleased to hear the offering from Virginia Department of Health about coming to them for timely data. So we'll be sure to do that. So while there's much to be done and on so many fronts, I think we would all agree in this room that the level of interest and desire to eradicate this epidemic is real, and it's here now. So I'd like to thank everybody for coming out, and for especially the words reminding all of us that we're really talking about a disease. And I think this is a great way to move forward in responding. I'd also want to give a quick shout out to two members of our working group, without whom all the comfort that you're enjoying, food, chairs, a name badge, Rebecca Hirsch and Sheila Davis, who have been just phenomenal in helping to make sure that all I's and all T's were crossed in that short timeline we had to present this symposium. So thanks to, yes. I'd also like to thank those of you who have volunteered to meet this afternoon and to delve further into a few topics. And we need to start promptly at 1 o'clock, so right after this, please proceed directly to lunch. And we're sorry we can't accommodate everybody. We do have some limited space, but we will welcome any comments or feedbacks or interactions as we move forward. So thank you all. Thank you.
you.